All, welcome to the second day of Annual Research Conference 2025. So we are going to begin our session of PG paper presentation. So for today's session, we got the judges, Dr. Hetal Rathod, Professor and Head, Community Medicine, Dr. D.Y. Patil Medical College and Pimpri, Pune, and Dr. Bhushan Chaudhary, Professor, Department of Psychiatry, Dr. D.Y. Patil Medical College, Pune. To chair the session, we have Dr. Swati Belsare, Professor, Department of Anatomy, and Dr. Santosh Rajamani, Professor, Department of ENT. I now request our chairpersons to introduce our judges.
Good morning. Introducing our judges, Dr. Hetal Rathod, Professor and Head of the Department of Community Medicine, Dr. D.Y. Patil Medical College, Hospital and Research Center, Pimpri, Pune. She is having total teaching experience of 19 years and 55 publications to her credit. She has received Innovative Teacher Award by DUP in 2015. She is working as member of Scientific Committee of College, member of Ethics Committee, member of Medical Education Unit of the College, and chairperson, panel member, and judge for various national and state conferences.
Very good morning. I would like to introduce our esteemed judge, Dr. Bhushan Chaudhary, Professor Dr. Bhushan Chaudhary, sir. He's a professor of psychiatry at the prestigious Dr. D.Y. Patil Medical College Hospital, Pune. He is the past honorary secretary of Association of Industrial Psychiatrists of India. He is a mentor and has guided many students, and he has 40 publications to his credit. In addition, his special areas of interest are internet addiction, psychological problems in medical students, and schizophrenia. Thank you.
Thank you, sir. Thank you, ma'am. I welcome you all. Before we start, I want to tell about the rules of the presentation for the postgraduates. The total presentation time is 7 minutes. At the 6 minutes, we are going to ring the first bell, and after 1 minute, the two bell will ring, which will indicate that your time is over for the paper presentation. 2 extra minutes will be given for the question answers. So we will begin with our first presentation. I request Dr. Priya Joshi from Department of Pathology to present her paper.
A very good morning, everyone. My name is Dr. Priya Joshi, Junior Resident from the Department of Pathology. Today I'm going to present paper titled Histomorphological Lesions at a Tertiary Care Center. Ovarian lesions can occur at any age. These lesions may be non-neoplastic or neoplastic in nature. Some of the non-neoplastic lesions of the ovary may present as a pelvic mass and mimic ovarian neoplasm. Benign tumors are cystic in nature, and presence of solid component increases suspicion of malignancy. Ovarian cancers are the 7th leading cause of cancer death among women worldwide. It comprises 8.7% in different parts of India. Therefore, their proper recognition and classification is important for appropriate management. This was a prospective descriptive cross-sectional study conducted from March 2024 to June 2025. It included all the surgically resected ovarian specimen obtained from total abdominal hysterectomy with unilateral or bilateral salpingo-oophorectomy, oophorectomy or ovarian cystectomy. After obtaining informed consent and ethics approval, specimens were processed using paraffin embedding, sectioned with a microtome, and stained with HNA. Histopathological features were studied and classified according to WHO guidelines. So a total of 50 samples were received in our histopathological lab. Out of them, 52% were non-neoplastic lesions, 38% were benign, and 10% were malignant. Majority of the patients were in the age group of 40 to 59 years, followed by 20 to 39 years. We received 96% patient had unilateral cases and 4% had bilateral cases. Out of all the non-neoplastic lesion, follicular cysts were the most common, followed by corpus luteal cyst. Out of all the benign neoplastic lesions, serous cyst adenoma was the most common finding, followed by mucinous cyst adenoma, and serous carcinoma was the most malignant lesion found. Coming to the histomorphology features, so we received a large ovarian cyst with external surface was smooth, and on cut section, chocolatey fluid oozed out. On microscopy, we can appreciate the normal ovarian stroma, which is overlined by the endometrial glands and stroma. So a diagnosis of endometriosis was given. So we're coming to the benign neoplastic lesion. So this is a large ovarian cyst which is having smooth and glistening surface. On cut section, it has no papillary projection and just clear cystic fluid was oozing. So this is, the cyst wall is lined by the flattened to cuboidal epithelium, and there is fibrous stroma. So the diagnosis was given as serous cyst adenoma. The second specimen, this is the ovarian cyst which is entangled with the hair or tuft, and on cut section, yellowish greasy sebaceous material was present and some amount of cartilage. So here we can see on microscopy, low power field, this is the cyst which is lined by the stratified squamous epithelium. We can also appreciate the sebaceous glands, hair follicle, cartilage. Also there is presence of intestinal epithelium. Place nuclei and eosinophilic to clear cytoplasm, hence the diagnosis of dysgerminoma was made. Second, malignant neoplastic lesion. So we received a total abdominal hysterectomy specimen. We can see this ovarian mass, which is having variegated appearance, fragile appearance, and with areas of hemorrhages and necrosis. So there are two components on microscopy which can be appreciated on the low power field. This is the epithelial component, which is having pseudostratification and hyperchromatic nuclei, and the normal mesenchymal component. So the diagnosis was given as carcinosarcoma. So out of all the 50 cases studied, 68% of the patients were in the age group of 40 to 59 years of age, which is consistent with the study done by Kaur et al., whereas Maru et al. And Prakash et al. Reported most cases in the 20 to 39 years age group. 96% of the cases had unilateral lesions, while 4% had bilateral lesions, which was consistent with the study done by Mishra et al. And Prakash et al. In our study, 52% of the lesions were non-neoplastic, 38% were benign, 10% malignant, consistent with the study done by Maru et al. Follicular cyst was the most common non-neoplastic lesion, consistent with the study done by Deepa et al. Serous cyst adenoma was the most common benign neoplastic lesion, which was again consistent with the study done by Maru et al. And Deepa et al. So, conclusion, ovarian lesions comprise variety of non-neoplastic and neoplastic lesions. In our study, non-neoplastic lesions were the most common than neoplastic lesion. Therefore, proper recognition of non-neoplastic lesion is particularly important as they mimic ovarian neoplasm and it influences management. Hence, histopathological evaluation plays a crucial role in both diagnosing and managing these cases. These are my references. Thank you.
So all these cases were the consequent cases that you have got from the gynecology
Yes, sir.
department?
Yes, sir.
Okay. And it is from your only center.
Yes, sir.
Were there any limitations?
Yes.
Were there any limitations in this study?
Limitations are in some part like high-grade malignancy tumors like carcinosarcoma. We had to do the extensive sampling and microscopy. And again, IHC was also required for diagnosing such cases.
Okay. No, like considering your objective, uh, would you like to mention some limitations?
Sir, we included all the specimens which were obtained, like unilateral or bilateral self-oophorectomy, all the self-oophorectomy specimen, all the ovarian specimens were included irrespective of the age group we received.
Okay.
All 50 you received and all 50 were basically
Processed.
evaluated.
Yes, sir. Yes,
Did you
ma'am.
receive more than 50 and some could not be processed?
Ma'am, more than 50, there were unremarkable ovarian.
That is what was the question.
Yes, ma'am.
And your JR1,
JR2, ma'am.
JR2. So, of course, research is very important here, but I just wanted to find out these cases have been diagnosed as so and so, non-neoplastic, neoplastic. What was your role? How much you could identify? Could you
Ma'am, I
di-
could,
Huh.
like I could see like microscopy features, how the process was getting done and everything I could.
You could do.
Yes, ma'am. Thank you, ma'am.
Our second presenter is Dr. Ankush Dhage, Junior Resident Ortho Department.
Hello, good morning everyone. I am Dr. Ankush Dhage from Department of Orthopedics. I am presenting paper on the topic of comparative study of functional outcome of extra-articular fracture distal end radius with closed reduction and traditional cast immobilization versus closed reduction with Kapandji spinning technique under the guidance of Professor Dr. Darpan Mahesh Gori. Distal end radius fractures constitute 16 to 18% of upper limb injuries. Inadequate treatment can severely impair hand function. Conventional plaster cast immobilization shows unsatisfactory results in 30 to 35%. Residual deformity in 60 to 65% of patients. Closed reduction with additional fixation methods have shown improved outcomes, and one such minimally invasive technique is Kapandji's intrafocal pinning technique. Aim of the study is to compare cast immobilization versus Kapandji's intrafocal pinning in elderly patients. Evaluate movements, grip strength, pain deformity, disability, and post-operative complications like infections. Materials and methods. Study design is a prospective comparative study in which sample size is a 60 patient and age group more than or equal to 50 years. Inclusion criteria: stable, displaced, extra-articular distal radius fractures, no gross comminution or severe osteoporosis. Exclusion criteria: fractures more than 21 days old, intra-articular fractures, severe comminution, congenital structural forearm anomalies, previous wrist or forearm fractures. Group allocation: in group 1, closed reduction plus cast, in which 30 patients, and reduction technique is Aziz maneuver under C-arm guidance. Aziz technique is traction, palmar deviation, and ulnar deviation. Group B is a closed reduction plus Kapanji's intrafocal pinning technique. Kapanji's technique is 1 to 1.5 mm K wires inserted intrafocally. 2 wires technique, dorsal ulnar and volar radial K wires are inserted, used for reduction and stabilization. As shown in image, pre-op X-rays of wrist in AP and lateral views, and post-op X-ray with Kapanji's pinning technique is shown. Post-operative care is taken with below elbow cast, limb elevation, antibiotics, spinning group, analgesics, calcium, and discharge after 2 days. Follow-up done on 1, 2, 4, and 6 and 12 weeks, clinically and radiologically. Outcome measures with visual analog scale for pain, Seattle chart for deformity and tenderness, and Linderstrom's criteria for anatomical and functional results. Results: in the cast group, mean age group is 62, and in pinning, 63 years is a mean age group. Gender frequency: males are 31% and female are 68%. In visual analog scale, in cast group 5.6 is a VAS score, and in pinning group 4.7 is a VAS score. That signifies that in pinning group pain is less. In Seattle score, which is for outcome, excellent is seen in pinning group, that is 50%, and good is seen also in pinning group. For complications were noted in both the groups. Finger stiffness is seen in 4% and cases of cast, and 2% in pinning group. Sudex dystrophy was seen in 13% cases of cast and 10% cases in pinning group. Pin tract infection was seen in 13% patients in pinning group, and osteoarthritis was seen in 20% patients in cast group. This signifies that all the complications are more in cast group than pinning group. Range of motion is also more in pinning group than the cast. Linderstrom's criteria, which is for anatomical and functional outcomes, in which cast groups has anatomical and functional outcome is less, and in pinning group, functional and anatomical outcomes are more in pinning group. Mean loss of radial length in cast group was 6.83 mm, and intrafocal pinning group was 3.80 mm. P-value was less than 0.03003. We did not observe significant displacement after pin removal. Thus, our study giving comparable results like other studies. Conclusion is that intrafocal pinning technique of Kapanji's is superior modality of treatment for fracture distal end radius, which are minimally comminuted without intra-articular extension and grossly unstable as compared to closed reduction and casting technique. Thanks.
It was a good presentation. Were there any particular selection criteria for patient for allocating this particular group?
Yes, sir. Age is more than 50 years because we want to see in the osteoporotic bones with cast and pinning group, because in less age both are mostly equal, but as age increases the pinning group has more significance.
No, I was asking for selection in your patient, right? You have allotted certain patient in cast group and certain patients in pinning group, or you have selected those post-operative patients like this.
Yes, sir.
That inclusion in your study was before study, or
sir, after
before intervention or after intervention?
After observing all the post-operative patients.
Okay. So these cases were basically just routinely cases happening in your hospital.
Yes, sir.
And you have just selected those patients.
Yes, sir. Randomly, sir.
Okay. Were there any that end result anatomical result, were there any significance
Yes, sir.
in statistical significance was there?
Yes, sir. As radial length, intra-articular space are more in pinning group, and in a cast group it was less.
Okay. So you have mentioned statistical significance in functional ranges. Yes. But then other parameters, were there also statistical significance? Because statistical test that you have applied in uh, functional range, right? That I have seen. For other parameters, matlab, I could not see that application of statistical test.
Yes, sir. All in the Seattle groups, which is for outcome, there is also statics. That intrafocal technique is better than cast.
Okay.
This was an observational study, right?
Yes, sir.
Was there follow-up?
Follow-up after 1, 2, 4, 6, and 12 weeks.
So that should have come very clearly in your methodology. Okay? So you had multiple follow-ups,
Yes, sir.
right? And
Yes,
the
ma'am.
final outcome you have presented,
Yes, ma'am.
right? So presentation was good, but when you are presenting, when you write mean value, you are supposed to add standard deviation along with that.
Okay, ma'am.
So in all your tables, standard deviation was missing.
Okay.
But do add. Okay.
Thank you.
So, our next presenter is Dr. Sagarika Basavaraj from Department of Pharmacology.
Good morning, all the judges and all the teachers and all my colleagues. I, Dr. Sagarika Basavaraj JR2 from the Department of Pharmacology will present my case, my research article, that is the evaluation of drug utilization patterns in geriatric patients with hypertension and type 2 diabetes mellitus at a tertiary care rural hospital. So, geriatric population is defined as a age group above 60 years of age, according to the Indian definition. And diabetes mellitus and hypertension are the rapidly emergent public health problems in these particular age group. So, lifestyle changes and even medications like antihypertensive medication and also medications for diabetes can help us deal with these healthcare problems. So, optimal glycemic control can help to treat diabetes and maintaining the blood pressure by giving the antihypertensive medications and can help us overcome this disease. So, my study aims to evaluate the drug utilization patterns for the drugs prescribed in geriatric patients having hypertension and type 2 diabetes mellitus, and also in condition which has co-occurring condition like that is diabetes as well as hypertension. So as I said, my study aims to study patterns of drug utilization in patients of geriatric age group having hypertension or type 2 diabetes mellitus or both hypertension and type 2 diabetes mellitus using the WHO core drug indicators. So my sample size is 150. So what are these WHO core drug indicators? They are the indicators used to analyze the prescription. Now there is a lot of irrational drug prescribing which can affect patients in a long run. Like for example, there can be decreased drug adherence. There can be increase in the cost of the treatment. So it can decrease the mortality and morbidity if we prescribe drugs in a rational way. So WHO core drug indicators helps us to prescribe drugs in a rational form. So my sample size is 150. Ethical approval was taken. My inclusion criteria is that patient of both sexes above 60 years of age from the medicine OPD was taken. We included patients of hypertension, type 2 diabetes mellitus, and conditions and patients having both diabetes and hypertension but were on medications. I excluded patients who were critically ill and patients having coexisting causes of hyperglycemia like Cushing syndrome, hormone secreting tumors, long-term steroid therapy. Now, the WHO indicators which are used, they were the average number of drugs prescribed per prescription, the percentage of prescriptions with injections, and the percentage of drugs prescribed from the list of national essential medicine or local formulary. So my data was collected in a case record sheet. So there was 3 case record sheets, one for hypertension, then diabetes, and also a case record sheet which has which recorded information of co-occurring conditions, patients of co-occurring conditions. And after we recorded all these details in the case record sheet, the percentage of the WHO, each WHO code drug indicators was calculated. And these were the results. So in figure 1, we can see that there were maximum patients of diabetes we could see in the OPD, followed by hypertension, followed by co-occurring conditions. The individual cases were more in females, but the co-occurring conditions were more in males. We could see that one drug was prescribed more in hypertension compared to diabetes, whereas 2 drugs were prescribed in all 3 conditions. 3 drugs were prescribed the least, and 4 drugs were prescribed mostly in conditions of diabetes. Where injections are concerned, only 2.57% injections were given. The good thing is the 97.43% of patients were given tablets and they were cured. The results were good enough. Percentage of drugs prescribed from essential drug list, which made the treatment cost effective and rational drug prescribing. So in hypertension, we could see 18.65% of individuals. In diabetes, 76%. In hypertension and diabetes co-occurring condition, we could see 22.51%. Whereas total 65.92% of medicines were prescribed from the essential drug list, which is very good and very cost effective. And we could see that in hypertensive patients, amlodipine was the most common prescribed medication, followed by losartan, enalapril, hydrochlorothiazide, clinidipine, and then telmisartan. In diabetes mellitus, metformin was the most common drug, followed by gliclazide, sitagliptin, voglibose, glimepiride, and last insulin. Whereas where both the conditions were concerned, we gave metformin, losartan. If you see the drugs which are acting on renin-angiotensin system were given. This is very important because if a person has diabetes and hypertension both, we cannot give beta blockers in these conditions because beta blockers mask the symptoms of hypoglycemia, which can occur in diabetes patients on medications. Like hypoglycemia presents with tremors, palpitations, and because when we give beta blockers, when we block the beta 1 receptor, it will mask all these symptoms. And also, beta blockers prolongs the hypoglycemia caused by the anti-diabetic medications. So that's why most patients were prescribed 2 drugs. Strong preference was to amlodipine. 97.43% people were given tablets, and essential medications were prescribed in 65% of individuals. Limitations were there was a small sample size, and thus WHO code drug prescribing indicators was used, and the average number of drugs prescribed per prescription, percentage of prescriptions with injections, and the percentage of drugs prescribed from the essential drug list or local formulary were noted in patients of hypertension, diabetes, and patients having co-occurrence of both these conditions. These are my references. Thank you.
Dr. Sagarika, the title is Drug Utilization Patterns in Geriatric Patients.
Yes.
Can you define what is your definition
Of?
drug utilization?
Okay, so drug utilization, it is a study to analyze the prescription. It analyzes the skills of the prescriber as well. So we want to make sure that we give most cost-effective
Then the
treatment to the
study is
patient.
prescription patterns for hypertension, diabetes,
Yes.
or drug utilization, because as per the whatever title you have mentioned, utilization by the patient,
Utilization patterns.
utilization of medicines by the patients. That
Yes.
is what is, we are deriving from your title.
Yes.
So you have not taken patients into consideration. You have just seen the prescription patterns.
Yes.
right, from the secondary data.
Yes, ma'am. Ma'am, but this data also helps us to analyze the cost effectiveness and how the patient adherence helps in the compliance of
How? How? It is not there in your presentation. How this is going to check on the compliance of
Okay, so
medications?
where my study was concerned, all the results were positive. All the medications were from the essential drug list. All there were minimum injections. So the
these were
patients.
prescribed, na? These were
Yes.
prescribed.
Yes.
Whether patients are taking them,
Yes.
was there part of your study?
No, not really, ma'am. That could be a limitation. Yes, to study the drug, to study the adherence of the medication, I can. Yes, that could be a limitation. Yes, I could have studied the adherence
That
pattern
was
as well.
your study, if you wanted to put this title.
Okay, so I could have named the title as prescribing patterns. you
Yes,
mean.
प्रिस्क्रिप्शन
Okay.
पैटर्न आपका पूरा स्टडी है कि क्या
Okay.
प्रिस्क्रिप्शन होता है. तो टू
Right.
ड्रग होता है, सिंगल ड्रग होता है. अभी से हाइपरटेंशन रहेगा, so depending on the condition may be single or two drugs.
Okay.
Diabetes may be like that, but combined रहेगा तो how many drugs the patients are being given. And
Right.
utilization is from the patient's perspective, whether patient is taking those medicines or not.
Okay, and why, ma'am, I use this title because the WHO co-drug indicators, when we see, the WHO has used this word, drug
Right, that's why I asked you
utilization.
this question.
Yes.
That's why I asked you this question.
So the WHO has included in their booklet this word, drug utilization. So I had to include that instead of prescribing pattern.
We can, but prescription, your study was on prescription pattern.
Yes.
That's fine.
Okay.
Okay.
Thank you.
Our next presenter is Dr. Vipul Pise from Department of Orthopedics.
Good morning. I'm the resident from the Department of Orthopedics. I'm Dr. Vipul. My paper presentation topic is the prospective study comparing the functional outcome of complex tibial plateau fracture using CT-based three-column theory versus X-ray-based Schatzker classification treated with open reduction with locking compression plates. So coming on to introduction, the tibial plateau fracture are the complex fracture where the mode of injury can be the high velocity trauma or RTA in generally the younger patients. But in elderly one, even the trivial trauma, like for example the fall, can even cause the tibial plateau fracture, which can be due to the osteopenia. So, so basically my paper is the functional outcome based on the CT versus the X-ray based Schatzker. Usually the Schatzker classification is the X-ray based. There are 6 Schatzker classification. For example, the type 1 is lateral tibial plateau fracture, the split fracture of the lateral tibial plateau. The type 2 is depression fracture of the lateral tibial plateau. Type 3 is pure center depression of the lateral tibial plateau. Type 4 is medial tibial plateau fracture, which can be the split depression, or type 5 is bicondylar fracture, and type 6 is fracture is such that there is metaphyseal diphyseal dissociation. So this is the classification based on the X-ray, radiograph, AP and lateral, which is the CT based. In three column classification, we divide the tibial plateau into 3 columns. So there is anteriorly the medial column and the lateral column, and posteriorly there is posterior column, which can be further subdivided into posterior medial and posterior lateral column. So so if any patient comes to our, if patients get admitted, so if the patient is an IPD patient, we first do the X-ray, the radiograph. Then we classify based on the Schatzker type 1, 2, 3, 4, 5, and 6. But and we, if it is a complex tibial plateau fracture, then we go for the CT scan. We ask the patient to do the CT scan. So sometimes CT may be CT, if sometimes due to the resource limitation, sometimes the patient may not be feasible, or due to the cost can be one of the issue. The patient may sometimes can't do the CT. So in this study, we have asked the patient to do the CT scan so that we can compare the functional outcome post-operatively, intraoperatively, and likewise we can modify the approach, the operative approach. So this was basically our study. And so coming on to materials and methods. So this was the prospective study, single-centered observational comparatively study, which was done in the Department of Orthopedic at our hospital. So total of 44 patients were taken, Group A and Group B. Group A were of Schatzker type. Group A were of CT-based, where the patients were classified according to the CT-based 3-column theory, while the Group B was the Schatzker-based, which was the X-ray-based. And we treated the patient with the compression plating. So it was only the approach and the functional outcome post-operatively we were to compare in this study. There were certain inclusion and exclusion criteria. Inclusion criteria were the patient greater than 18 years old were included in this study. Then exclusion were even the Schatzker type 5 and type 6 were included in the study. So patient greater than 18 years of age and Schatzker 5 and 6 were inclusive. Then excluded were patients greater than 65 years old. Patients were excluded. Then patients Schatzker type 1 to 4 were excluded. Patients, those who were not fit for surgery or those who were not willing for the surgery were excluded. Even the compound injuries patient were excluded. The joint dislocation were patient of the exclusion. So all the surgeries were performed by a single senior orthopedician surgeon, assisted by the same team. We followed the standard operative protocol with consistent perioperative management and post-operative rehabilitation therapy were given. Patient was immobilized with above knee slab. And post-operatively at post-operative day 14, sutures were removed, and patient was non-weight bearing for 6 weeks. Then we started the partial weight bearing, the toe touch weight bearing. So we assess the outcome based on the Ramsden score. So the functional outcomes were assessed by the Ramsden score. So Ramsden score contains the pain component, then knee extension, then patient means the patient is able to walk. So higher is the score, better is the prognosis. So I already have told that Group A and Group B. Group A was CT based and Group B was Schatzker based. So the follow-up were taken at 6 weeks, 12 weeks, 24 weeks, and 36 weeks. We can see that functional outcome with CT based was good at 23.2 plus 2.5, while of the Group B was 21.7 plus minus 3, mean plus minus standard deviation. So it was high for the Group A, which was the 3D CT column type. But for Group B, it was the low. So higher is the score, better is the prognosis. Then post-operative complications like for wound infection, for Group A, it was comparatively low with respect to the Group B. The wound infection, then loss of reduction, joint stiffness, post-traumatic arthritis, delayed union or non-union. So So finally, coming to the end, the discussions ends like the management for the complex tibial fracture, it's challenging. But when we do the CT scan, the 3D CT evaluation, the functional outcomes is better versus the Schatzker, the X-ray based, the functional outcome is not so good. So I already have told the limitation. CT can be the cumbersome due to the cost or the resource limitation. So I end with the conclusion that the 3D CT based approach is the better for functional outcome, for post-operative complication-wise. The 3D CT would be much better compared to the X-ray, and accordingly the operative plans, the patient operative plans changes. Thank you.
In your methodology, I think you had mentioned after inclusion and exclusion criteria, you had allotted patients into either group.
So,
In your methodology, after satisfying inclusion and exclusion criteria, you had allotted patients into either group, right? This was your methodology.
methodology means we had 44 patients. So each patient's 20 to 22 in either of the group. So we excluded the patient with the compound fracture and those with greater than 65 because only the trauma patient we considered in the included in the criteria.
It is like you had allotted patients into either group or you had just selected patients from either group. That is what I wanted to ask.
Means we selected the patient. So
You selected the patient.
yeah, we
from either
selected the
group.
patient. We excluded above
methodology.
65. Only the mode of trauma, high velocity trauma patients were only operated, were considered in this study.
Right.
The statistical test you have used?
Ma'am?
Which statistical test you have used? You have written na p-value less than 0.0.
Yes, ma'am.
Which test you have
Ma'am,
used?
Fisher's test.
Fisher.
Yes.
It was mean and standard deviation, na?
Mean plus mass standard deviation.
हाँ, so दो group का mean and standard deviation था. So which method, which test? Okay, and how did you calculate your sample size? Okay, ठीक है, कोई बात.
We have our next presenter, Dr. Bhagyashree More from Department of Psychiatry.
Good morning, everyone. Myself, Dr. Bhagyashree More, junior resident from the Department of Psychiatry. Today, I am presenting a paper on the topic of association of vitamin B12 deficiency with symptomatic profile and the neurocognitive function in the depression patient. So let's start with the introduction. Depression stands as the one of the most prevalent mental disorder on the global scale, posing a significant public health challenges. It is prevalent enduring mental condition impacting cognitive, emotional, and the physical well-being. It is marked as the diminished mood, energy level, persistent sadness, sleep disturbances, and the reduced self-worth. The prevalence of depression is on the rise globally, with 264 million individuals of all age groups affected by depression, according to the WHO. The depression encompasses deficiency across multiple cognitive areas, impacting attention, memory, learning, and the executive function. Despite the growing recognition of the interplay between depression and vitamin B12 deficiency, there remains a paucity in research investigating their relationship, impact, and the cognitive consequences, particularly in the Indian context.
So the proposed study aims to address this gap by examining the symptom profile and the neurocognitive deficit in patients with vitamin B12 deficiency depression compared to those with non-vitamin B12 depression. So the aim of my study is to evaluate the association between vitamin B12 deficiency, symptomatic profile, and the neurocognitive function in the depression patients. And the objective were to determine the prevalence of vitamin B12 deficiency, to compare the cognitive function by vitamin B12 status, to correlate depression severity with vitamin B12 deficiency, and to assess the symptom profile. So it was the cross-sectional analytical study conducted in the psychiatric OPD and IPD of the tertiary care hospital on 126 patients on the duration of 6 months using a purposive sampling. Inclusion criteria for the group A were those participants diagnosed with depression as per ICD-10 having vitamin B12 level less than 200 picogram per ml, and those having more than 200 picogram per ml assigned as a group B. Age of the participant should be between 18 to 65 years for both the group. And those having any other psychiatric illness and the medical comorbidities, they were excluded. These are the instruments and questionnaires used for my data collection. This chart shows the method of collecting data. So initially, patient information sheet and consent form given to all the participants who satisfying the inclusion criteria with assurance of confidentiality. Basic information pro forma were taken, basic scales were applied, blood sample collection for investigating vitamin B12 were taken after consent. Then it is divided into the two groups, group A and the group B, and the finding will be assessed as per the objectives. And the participant from the group A refer to the physician for the correction of the vitamin B12 deficiency. These are the statistical tests used in my study. So moving towards the observation and result. So table 1 shows that most of the participants are the female, that is among 126, 67 were the female, and they are the middle age group. And most of the patient, that is among 126, 77 patient has the short duration of illness, that is less than 1 year. And among 126 patient, 51 patient had the vitamin B12 deficiency. Then in the present study, common symptoms include suicidal ideation, loss of interest, agitation, psychic anxiety, somatic anxiety, and the initial insomnia. Moderate frequently symptoms are somatic symptoms, gastrointestinal symptoms, and the guilt feeling. And less commonly are the hypochondrosis, late insomnia, and the psychomotor retardation. So comparison of all ACE3, FAB, and HAM-D score were performed, and it shows that there is a significant differences were found. And that indicates that patients with deficient biomarker level had the poorer cognitive performance and they have more severe depression. So this graph shows that according to ACE3, we compare in both the group, and it shows that language, attention, and memory are the mostly common affected domain in vitamin B12 deficiency group. Similarly, similarly executive function were also assessed using the FAB, and it shows that inhibitory control, prehension, and the interference were most commonly affected. Then severity of depression were assessed using the HAM-D, and it shows that moderate and mild depression were most commonly seen in the vitamin B12 deficiency patient. Moving toward the discussion, vitamin B12 deficiency affect both neurological and the psychiatric domains. And the mean age of the study includes 35.7 years, and that is 61%. Then HAM-D were assessed, symptom profile were assessed by the HAM-D, and it shows that depressed mood is present in 100%, loss of interest is 99%, and the anxiety is 95%. While the neurocognitive assessment were also done with the help of ACE3 and the FAB score, and it shows that 70.1% attention, memory, fluency, language, visuospatial were deficient in the vitamin B12 deficient group. Then my novel finding of this study is even the younger adult with depression shows that there is a strong association between severity. And clinical implication is that routine screening of vitamin B12 in all patients with depression is recommended. So the conclusion is vitamin B12 deficiency is strongly associated with cognitive deficit and depressive severity. So the screening and correction needed across all the age group. And so early detection and correction of vitamin B12 deficiency can improve the cognitive and psychiatric outcome. So it prevents the long-term neuropsychiatric consequences. Thank you.
Good presentation.
Thank you, ma'am. In general population. Ma'am, my study is vitamin B12 deficiency and
I know,
depression.
I understood. I am just
Yes,
asking
yes.
you.
It's common, ma'am, actually.
It's common.
Yes.
It's common, right. So that is one of the factors you have to keep in your mind.
Yes, yes.
Right. Okay. How did you calculate the sample size?
What, ma'am?
Sample size calculation?
Sample size calculation I did with the help of previous study, prevalence of the previous study, and using the statistical test, I calculated the sample size.
Right.
126 is the sample size, ma'am.
Sample size. Sorry. Okay. Okay. Good. Any other question?
Thank you, ma'am.
Our next presenter is Dr. Akshay Rao from Department of ENT.
Good morning, respected dignitaries, seniors, and my fellow colleagues. I am Dr. Akshay Rao, second year junior resident from Department of ENT, presenting you a paper on impact of malleus-related graft placement in shaping hearing outcome in patients undergoing type 1 tympanoplasty. Tympanoplasty repairs tympanic membrane perforation and restores hearing in chronic otitis media. Reconstruction uses two options, either underlay or overlay. Underlay technique includes elevating the tympanomeatal flap along with tympanic annulus and putting the graft, temporalis fascia graft, either over the handle of malleus or under the handle of malleus. While on the other hand, the overlay technique includes elevating only epithelial layer of tympanic membrane and putting the graft lateral to the annulus. Chronic suppurative otitis media frequently leads to hearing loss and chronic otorrhea. Tympanic membrane in contact with graft is essential for perforation closure and airborne gap reduction. Puriton audiometry is used to assess the hearing loss of patient. Our study is done in a tertiary care hospital with prospective analytical study design over a duration of 6 months. 2 groups were made, 10 patients in each group were taken, so total sample size was 20. We have included patients with central perforation, dry ear for more than or equal to 6 weeks, and patients aged between 18 to 60 years of age. While presence of cholesteatoma, tympanosclerosis, ossicular chain erosion, previous surgeries and intracranial complications were excluded. The primary outcome of our study is airborne gap reduction on Puriton audiometry with subjective improvement of hearing. We have collected data by preoperative history, clinical examination along with otoscopic findings and Puriton audiometry. 2 groups were made. Group A, in which temporalis fascia graft was placed over the handle of malleus, and in Group B, it was placed under the handle of malleus. The decision for graft placement was taken intraoperatively by the operating surgeon according to integrity of handle of malleus. The postoperative Puriton audiometry was done at 3 months. Informed consent was obtained from all the patients. These are the pictures of normal Puriton audiogram, and American Speech Language Hearing Association grading system was used to assess the hearing loss. No additional cost was taken from the patient. Collected data was entered in Excel and paired t-test was applied. Our study helps to identify which graft placement technique provides better hearing outcome. Coming to the crux of our presentation, the results. Group A and B, pre-op ABG and pre-op PTA, having value of less than 0.05 p-value, while the post-operative the value is the more than 0.05, while the post-operatively the value is less than 0.05. Coming to the individual results, in Group A and Group B, paired t-test was applied and it was found that the p-value in both the groups was less than 0.05. But as we see the post-operative mean plus minus standard deviation of both the groups, in Group A, ABG and PTA having values of 16.4 and 30.5. In Group B, the values are 10.8 and 24.2. So this suggests that the Group B has achieved better hearing outcome and greater reduction in post-operative airborne gap closure as compared to Group A. Coming to discussion, in present study, both the techniques improved hearing, but under the handle of Malleus achieved greater ABG closure, approximately 18 decibels, and in group B, it was 12 decibels, indicating superior functional outcome. The Roga et al. Reported better postoperative hearing with medial, that is under the Malleus graft placement, due to improved ossicular coupling, supports our finding. The Kulduk et al. Demonstrated higher PTA gains with medial to Malleus grafting, especially in larger and anterior perforations, similar to greater gains in under the handle of Malleus group. Stage and back showed reliable hearing improvement with underlay medial graft placement, aligning with superior PTA improvement observed in our study. I would like to conclude that under the handle of Malleus approach consistently produced greater reductions in airborne gap and superior gains in PTA threshold with statistically significant differences compared to over the handle of Malleus group. Placing the graft under the handle of Malleus provides more efficient sound conducting interface and anterior perforations. Thus, the under the handle of Malleus graft placement may be preferred technique for optimizing better postoperative hearing outcome in type 1 tympanoplasty patients. These are my references. Thank you.
Were there any specific indications for a particular technique?
Yes, the patients in which the handle of Malleus was foreshortened, means the handle of Malleus is medialized. In those patients, we have cut the tendon of tensor tympani, pulled the handle of Malleus laterally, and in those patients, we put the temporalis fascia graft under the handle of Malleus, so that it maintains the normal annular malleolar integrity, thereby better transmitting sound.
Is it related to a disease process?
Yes, sir.
Severity of disease process?
The chronic suppurative otitis media, in which the tympanic membrane got central perforation, so due to which the handle of Malleus gets retracted, we can say, means it is foreshortened. It goes and touches promontory because the tympanic membrane is perforated. The lateral support of the handle of Malleus is lost, so the medial support will automatically pull the handle of Malleus towards it, that is medial.
The functional outcome. Did you study complications in both the
Yes,
methods?
complications was lateralization or medialization of graft, residual perforation, then serous otitis media.
So was it more in any of which method it
Yeah,
was more?
the patients in which we have put the temporalis fascia over the handle of Malleus has more chances of lateralization of graft, while on the other hand, the graft was under the handle of Malleus. So the chances were less as compared to the group A.
Okay. Okay.
Yes, thank you.
Thank you, Dr. Akshay. I now invite Dr. Onkar Chauhan.
Good morning. Today I'll be presenting my topic, prospective comparative study of functional outcomes of metacarpal fractures with plating versus K-wiring, under the guidance of Dr. Santosh Borkar and Dr. Shivraj Konde, sir. So this will be my overview. I'll be explaining the introduction, the aims and objectives, materials and methods, variables that will be studied, the statistical analysis, the result and discussion, and conclusion, and the references. So metacarpal and phalangeal fractures accounts for 18 to 44% of musculoskeletal system fractures. Two major causes of these fractures are roadside accidents and machine injuries. Considerable judgment is required to select the appropriate modality. A closed approach is preferred in stable and undisplaced hand fractures. Open approach is inevitable in unstable and displaced hand fractures. K-wires has many advantages, such as being economical, minimal invasive, and easily available. K-wiring can result in infection, non-union, and malunion. On the other hand, plating techniques can result in the implant failure, implant irritation, and skin necrosis. Simple classification on the basis of anatomy, the head fractures, neck fractures, the shaft fracture, and base fractures. The aims and objectives of my study will be to evaluate the clinical and radiological outcomes of metacarpal fractures treated with ORIF plus plating, and close reduction, open reduction plus K-wire fixation. The objectives will be to compare functional outcome of patient operated with open reduction internal fixation plus plating and close reduction internal fixation or open reduction plus K-wire fixation for metacarpal fractures, and to compare results of both modalities of treatment in terms of radiological union time, range of motion, grip strength, and dash score, that is the materials and methods. A prospective cohort study was conducted in Department of Orthopedics, MIMAR, Medical College, and Dr. B.S. TRH Hospital, Talegaon, Pune. A selection of cases was done, including all the patients with metacarpal fractures who are satisfying the inclusion and exclusion criteria. The study setting was done in a tertiary care hospital. The study design was prospective cohort study, which was a comparative study, and sampling size was 20 patients in each group, that is a total of 40 patients. And sampling type was purposive sampling, and sampling was consecutive. Inclusion criteria. All patients with age limit 18 years onwards, both male and female, skeletally mature patients with closed, displaced metacarpal fractures and fracture less than 3 weeks old. Exclusion criteria. Patients with pathological fractures, patients with compound fractures, patients with intra-articular extension of fractures, and comminuted fractures more than 3 weeks apart. Detailed history was taken, including onset and mode of injury. Thorough general and local examination was done from head to toe. Patient's vitals stabilized and assessment of distal extremity movements to confirm no neurovascular deficit. X-ray, AP, and oblique views of hand was done. Fractures were classified, stabilization with application of Cock-up slab in Edinburgh's position with minimal traction. No necessary investigations conducted for surgical fitness. And post-operative X-ray was done in AP and oblique views of hand of the patient. Initial intravenous antibiotics were administered, followed by oral antibiotics. From post-operative day 2, physiotherapy was started. K-wire removal was done after 4 weeks, and follow-up was done with appointments at 2nd week, 6th week, after 3 months, 6 months, and 1 year. Imaging and clinical examination at each visit to assess the fracture in union and functional recovery was done. Variables that were studied were age, sex, mechanism of injury, body mass index, time since injury, site of injury, location, that is the base, neck, and shaft, and comorbidities. Primary outcome variables were measured were range of motion, which was measured by goniometer, grip strength measured by dynamometer, and dash questionnaire. Secondary outcome variables were time for union, implant-related complications, that is implant failure, implant irritation, implant loosening, etc. And other complications like infection, malunion, non-union, wound dehiscence, and skin necrosis were studied. The materials used were as follows. On the top right corner, we see the mini plates that were used for the fixation, and bottom right, we see the K-wires and the required instruments. This was the pre-op, intra-op, and post-op fixation of plating. And these were the images for pre-op, intra-op, and post-op for K-wire fixation. The statistical analysis. Data collected was entered in Microsoft Excel 2019 and analyzed using IBM SPPS 21.0. Categorical variables presented as frequency percentages, continuous variables as mean standard deviation. Comparison of categorical variables was done using chi-square test and continuous variables with unpaired t-test. P-value of less than 0.5 was considered statistically significant. The data was analyzed, interpreted, and visualized with charts like bar diagram and pie charts. Results and discussion. On the basis of mean years of age, there was no statistical significant difference. According to gender, there was no statistical significance, and according to BMI also, there was no significant difference. Comorbidities, diabetes and hypertension were observed in 10% and 7.5% of cases in our study. According to site of injury, right-sided, because most of the people are right-side dominant, it was mostly seen in right-side fractures. Mode of injury was RTA, which was the most common. and the location of fracture was the shaft of metacarpal, which was 80%. And according to site of fracture, it was the little finger that was affected the most. According to mean time since injury, there was no difference in both the fracture healing. According to duration of stay, there was no such difference. But according to mean union time, we see the plating group took 6.8 weeks, whereas the K-wire group took 8.5 weeks, which was a difference, a significant difference. Mean ROM also showed a difference, where plating group the ROM was confident at 6 weeks and 3 months in K-wire group. The mean grip strength, significant improvement was seen at 6 weeks and 3 months, and complications, there was no difference in complications, and functional score, DAS score was seen. So I would conclude that this study highlights that metacarpal fractures predominantly occur in individuals over 40 years with a male predominance, right-sided fracture, that little finger, and road traffic accident as common mode of injury. Comparatively, plate fixation demonstrates superior outcomes, including stability, early joint function recovery, and improvement, alignment, grip strength, and range of motion. Faster union time, lower post-op complication rates, and better DAS score, emphasizing its superiority over the K-wire. Therefore, the findings suggest the plating is more effective and favorable treatment modality for managing metacarpal fractures. Hence, we conclude the same. These are my references. Thank you.
That was only about the statistical method, probably. That t-test.
Yes, sir.
You had applied. Presentation was very good. Otherwise, only thing was about the statistical test. Do you feel that that t-test is appropriate, or any other test?
Sir, for categorized data, unpaired t-test was a better option, sir.
Okay.
Sorry, the paired t-test was
Continuous
also.
variable.
Yes, sir.
Did you check for difference between the BMI using a statistical test?
Can you repeat the question, ma'am?
Difference between the BMI, you have checked.
Yes, ma'am.
And you have applied statistical test.
Yes, ma'am.
Why?
Ma'am, because when we see intraoperatively for obese patient, the like for it achieving the fixation, it is more difficult for higher BMI patients, ma'am.
Right.
That's why it was important.
But did you do that? Did you check the functional outcome in BMI,
Yes,
where
ma'am.
BMI was more and BMI was less? Did you check that?
Yes, ma'am.
It was not presented
It
in your...
was not mentioned.
It was not
Yes.
mentioned.
Yes.
Okay.
Thank you, ma'am.
So this was our last presentation of the session. I request our chairpersons and judges to please come on the stage. Welcome, ma'am. Welcome, sir. So I request Dr. Swati Bilsare to felicitate Dr. Hetal Rathore, ma'am. Thank you, ma'am. I now request Dr. Santosh Rajamani, sir, to felicitate Dr. Bhushan Chaudhary, sir. I now request Dr. Rupali Babodikar, Professor and Head Department of Physiology, to felicitate Swati Belsare, ma'am. And I request Dr. Shashank Vegbatak, sir, to felicitate Dr. Santosh Rajamani. Thank you, ma'am. Thank you, sir. By this, we conclude the paper presentation session of the postgraduate students. Thank you, judges. Thank you, chairpersons. Okay. Uh, Participants who has presented the paper can collect their certificates of paper presentation from the reception counter.
to the second day of the 13th annual research conference of Mimar Medical College. The organizing department this year are psychiatry, orthopedics, and pharmacology. Hence, the theme of the conference is Mind, Movement, and Medication, an integrated approach to healing. I would like to start the day with the inspiring talk on healing minds by Dr. Dhananjay Ashturkar. So to chair the session, it's my pleasure to invite Dr. Darpan Mahesh Gauri sir and Dr. Santosh Kumar Rajmani sir onto the stage to chair the session. I would like to introduce Dr. Darpan Mahesh Gauri. He is a professor of orthopedics and a medical superintendent of Mimar and Dr. BSTR Hospital. He's completed his MBBS from BJ Medical College with distinction and MS from Sancheti Institute. He has been a PG guide of since 10 years and has nine publications to his credit. The second chairperson, Dr. Santosh Kumar Rajmani, is a senior professor in ENT and has 15 years of academic, clinical, and administrative experience. He has strong expertise in research methodology and innovation. He has a special interest in artificial intelligence-driven research, and he has a number of 21 index publications, as co-authored many books, like 21 books, and 6 patents to his credit. It's my pleasure to invite Dr. Dhananjay Ashturkar onto the stage. Welcome, sir. I would request Dr. Darpan Mahesh Gauri sir to kindly introduce our esteemed guest speaker, Dr. Dhananjay Ashturkar, and conduct the session.
Good morning. On behalf of Mimar Medical College and Dr. Bausaheb Sardesai Talegaon Rural Hospital, I wholeheartedly welcome Dr. Dhananjay Ashturkar, who is a leading psychiatrist in Pune. He is the director of Astha Psychiatric Nursing Home, one of the largest mental care facility in that city. He completed his MBBS from GMC Nanded and DPM from GS Medical College, KEM Hospital, Mumbai. He's been practicing in Pimpri-Chinchwad area since past 20 years and has a teaching experience of more than 5 years. He has been the past secretary of the Indian Psychiatric Society, Maharashtra branch, and Pune Psychiatrists Association. He is the immediate past president of Pune Psychiatrists Association and also Indian Psychiatric Society, the Western Zonal branch. He is also the executive member of the Society for Mental Health Awareness, Research, Training and Teaching. Interesting topic, that is the healing mind, and we'll be discussing the psychological determinants of physical recovery. So I invite Dr. Ashturkar to deliver his talk. Thank you.
Thank you. Thank you, Darpan sir. Thank you, sir. Thank you, Department of Psychiatry, Orthopedics and Pharmacology for inviting me. Can I have my presentation, please? So today's topic, which I have been allotted, is a healing minds and psychological determinants of physical recovery. As since yesterday, we are learning about the relationship between mind and brain, mind and body. So this is going to be very important aspect of the healing during the physical recovery. Dr. Anish called me few days back and asked me to deliver the topic on this. मी असं काही म्हटलो नाही. I said yes, I am in. Challenges, after I said yes, and then I thought little bit, and I found some challenges. First challenge, if your spouse is there in the faculty of particular institute, so it becomes little bit difficult to go there and deliver lectures. If the Department of Psychiatry is full of your friends, it becomes doston ki izzat ka sawal, you have to perform well. Third, if your teacher, yesterday, Dr. Hinal Shah, delivers excellent keynote address on neuroplasticity, brain, and everything, so it becomes more difficult. And lastly, the topic, which is definitely for a practitioner psychiatrist, it's an unusual topic which I am going to speak. So these are the challenges I thought throughout the day after saying yes. But as a psychiatrist, what we do with the patient, the same I applied on myself. I thought, if your spouse is there, it's good that she will feel better if you are going to be there. If your friends in the Department of Psychiatry, मित्रांचं असंच असतं ना, they will not criticize you, at least in the public. Even the lecture had not been delivered up to mark, they will defend you. Nani, our choice was good. It's honor to be on the same dais where your teacher was there yesterday. And about the topic, I thought, definitely it's an interesting one. It gives me the chance of new learning, which is the aspect or area which I have not explored yet. And there is no definitive line of, clue. Nobody has a clue in the audience also what I am going to speak on. So that's good for me. And for next 30 minutes, maybe I am the director. Here I wrote, I am a director. My daughter said, no, you have to write, you are the director. Because you are going to carry the show for next 30 minutes. So friends, let's do it. I am not saying I will do it. I am saying let's do it. So first start with the case. Because we are in the medical college and there are a lot of academicians are there, so better, I thought, using a case. Here, Miss A, 28 years old lady, unmarried, right-handed, well-educated, from upper middle class family, IT professional, doing most of the work from home or hybrid kind of job, came to casualty with history of fall and inability to move left hand. There was pain, there was swelling over the left forearm. X-ray forearm shows fracture left shaft of radius and ulna. This is something like that. Any ortho resident here? Senior resident? No? Yes. What could be the management? Please, sir. So, Mike.
Thank you, sir. So I'm Dr. Rajiv Munde. Although we are the surgeon, although patient comes to us, first of all, we counsel the patient when something happens to them, not directly the surgery and the plaster and all those things. We give at least 5 minutes to the patient. They explain to them what has happened. We draw the diagram. We saw the bone models, and let understand patient what has happened to her. Then we prescribe further treatment.
So, as you said, there are 4. If you say as duration of treatment maybe for few weeks, like my Aji used to say, झालं fracture, 1.5 महिना plaster. So that kind of period is there. But what could be the impact of this fracture on that lady in her day-to-day life. I pursue, if I go back to the case, I feel that as she is unmarried, she is right-handed, she is IT professional because she doesn't have to work much, go out, she can do work from home. So overall, this 1.5 month may be impact, I will not say not nil, but there will be mild. The same case, if 28 years old lady married, having toddlers, toddlers, twins, she is from the same profile, so, but quite be, the impact will be moderate because she has to take care of children, she has to take care of job and all the chores. The same case, same age group lady, married, having 2 children, from low socio-economical class, she might be ayah of some hospital or housemaid. So treatment plan will be, your treatment plan will be the same, sir, for all cases, right? But the impact will be severe here because she will lost her earning, daily wages, and she might have to take a rest for 1.5 months because she could not work, do the housemaid job. So impact will be severe. The same case from upper middle class lady, well educated, but here she is a player. And she has to go for the tournament. She has been selected from at the national level. So obviously, impact will be severe. The same 28-year-old, some different lady, married, having 2 children, left-handed, educated, which we had seen the same thing, but she stays in a joint family, having good social support. Might be, I feel, overall impact will be mild to moderate, not that much severe, which already are there. And obviously, I am taking one chronic case, 54-year-old lady, well-educated, homemaker, came with history of pain and swelling of joints since last 2 years, with restricted activities in last 6 months. So treatment plan may be, as you said, which may be for rheumatoid arthritis, there will be a different treatment plan. But here, the overall duration of illness may be possibly lifelong. She has to follow the treatment, and impact will be obviously moderate to severe level. So friends, all these socio-demographic factors play an important role in determining the path of recovery and remission. These are like a biomarkers, these are also the prognostic markers, and it varies case to case. What are those factors? This is the nature of illness, whether the nature is acute or chronic, duration of the treatment, which remains for the few weeks or lifelong, onset of illness or age, at which age illness has appeared in the life, prognosis, good, bad, or guarded. What is your treatment plan? Obviously, the treatment plan varies from disease to disease, and that may also the factor which is going to decide our prognosis. Complications of the treatment, sequelae of the illness per se, economical and social and cultural beliefs, family support, and of course the quality of life. So these are the psychosocial determinants. There are biological determinants also, which since yesterday we are learning all this about the mind-body relationship, illness, injury, acute or chronic stress response of our body, HP axis dysregulation, role of cortisol, pain pathways, inflammation occurred due to the chronic stress, and obviously what we learned about the neuroplasticity yesterday. But only the psychological or biological or social factor are not going to decide the prognosis of the case. It is the biopsychosocial model. The biopsychosocial model is a holistic framework viewing the health and illness as a result of the complex interaction between the biological factors like genetics, physiology, physiological factors, psychological factors, which we are going to see in next few slides. And as we learned, there are social factors. The social, biological, and psychological factors are interlinked. It's like everywhere, if you find nothing like only biology, only social, or only psychology, is in word, we call it as the Jangad Gutta. There is a confusion, lot of interactions. So what are the psychological factor? I read few articles, I read few slides which Ashish has sent me, which information, and I conclude that there are only 3 factors which we can cover up. First is a health belief, illness perception, and health locus control. Second, which you might not that much aware of, that is a defense mechanism. And third is a personality traits or types. So we will go one by one. This is model is existing in our medical profession since 1950s. This is very basic model and very explanatory. How we pursue the seriousness, it's about the health, it's not about the illness. How we pursue our health, how we pursue the seriousness, and this model is usually used in very awareness programs, how to, for example, quitting smoking, quitting drinking, positive lifestyles. So all these things covered with the help of health belief model. This is about the normal health. What we pursue about our illness is also important thing. This is the common sense model which has been Leventhal has given. This is the interpretation, coping, and appraisal, where individual try to make sense of symptoms. How we understand our symptoms, how we act to manage the symptoms, how we judge their success and impacting adherence and outcome. Health locus control is simply like what patient we usually day-to-day find. Either they find internal control or external control. Means, for example, if we diagnose somebody with the hypertension, that if some person feel that कि नहीं, ये problem मुझ में है, then I have to do something. Means I have to do exercise, I have to change the things, I have to might have diet restrictions. And other persons, we maybe feel that it's external control, like my doctor will decide what to do rather than what I. So sometimes even the external control, external loci may be less distressful because we feel that somebody is responsible for our health or our illness. Health belief, illness perception, health locus of control are going to decide to some extent person's attitude towards health, illness, treatment, and approach to health services. There is another thing, interesting thing, that is a defense mechanism. Any then other than psychiatrists know this thing, defense mechanism? This is concept formulated by the Sigmund Freud and conceptualized by Anna Freud, daughter of Sigmund Freud. It's something, you know, we are doing unconsciously many things which we are not knowing in a conscious mind. To handle the guilt, we forget so many memories, we bury so many things in our life in mature way or immature way. So this becomes, this internal conflicts, we can cope with the internal complex and the stress in the life-threatening way. Usually these are the defense mechanisms, projections, there are some mature defense mechanism, there are some immature defense mechanism. If patient plays immature defense mechanism, then there will be difficulty in your treatment plan. What are those immature defense mechanisms? Like denial. काही होत नहीं रे, nothing happens. कोई नहीं, डॉक्टर तो बोलते रहते हैं मगर कुछ होता नहीं. Even there is problem that they are having chest pain, they are having severe pain, headache, they will in the denial phase. They will refuse to accept the reality to protect their guilt. Some minimizes the problem. Like many alcoholic patients we see, they always never says that they are drinking 3 quarters. They will say, nahi, 90, roz 90s gheto ami. That is the minimization of the problem. Even if you see our grandmothers, grandfathers, they always minimize things. जस किती जरी कंबर दुखत असली तर नाही तेवढी नाही आहे कालच्यापेक्षा बरं आहे सो दे ट्राय टू मिनिमाइज द थिंग्स सो दॅट इज द immature defense mechanism which is going to affect our treatment plan. Projection, blaming others for our problem. Maybe blaming our family members, blaming situation, maybe some other things, even the health system. So this projecting the emotions, which is also a immature defense mechanism, which can cause trouble in our treatment plan. यहाँ पे कुछ डिपार्टमेंट में हो जाता है देन वी डिस्प्लेसेस एंगर एट होम सो दिस इज अनदर immature defense mechanism in health when health is concerned. And rationalization, we try to rationalize many times because we want to protect our ego. Nahi, what is this, everybody happens, it happens everywhere, everybody drinks, nothing, it's kind of social kind of thing. Or even everybody nowadays everybody is having diabetes, ये तो फार्मा वालों का या फिर इनका ये होता है कि हर वक्त they shift the lower borders. So these are the rationalizations. So all these denial, minimization, projection, which may not be consciously we are doing, our unconscious mind is doing, but these are all immature defenses which are going to cause problem in health seeking, to the approach to the health system, and also following the treatment plan. See, another important thing, even if you apply same treatment to 4 people or 4 patients, results will be different. It's because of the personality of that person. Sorry. What is personality? Personality is a unique but relatively stable pattern of thought, emotions, and behavior that define how an individual consistently think, feels, acts, and shaping their distinctive way of interacting with the world. Definitely, this personality gets influenced by the genetics, what you called as nature, and by environment and experiences, what you called as a nurture. So personality is a bunch of traits. Means personality ऐसी होती है ना, for example, you can predict your friend. नहीं, this is situation, Ashish Ubale will act like this only. Because I know Ashish since maybe for 4 to 5, maybe for 14 years now. So I can predict his personality. नहीं, Ashish है ना, तो ऐसे ही होगा. So why we are knowing? Because we understand his relatively stable pattern of his thoughts, pattern of his feelings, and the pattern of his behavior. So predicting can be possible if you know personality traits. So there are few specific personality traits which I am going to highlight. There are few personalities which are very much paranoid. This you may find it in a patients also or people around you. It's up to you. So these persons with the paranoid traits, it's not something like somebody I am saying paranoid, he is a paranoid. That doesn't mean he might have other traits also, definitely. But prominent trait is a paranoia. Paranoia means these patients are very much doubtful, suspicious. They will ask too many questions to you. They want to clear each and every doubt. So there is trust issue. So why it is important to understand whether the patient is a paranoid or not? Because you cannot be establish a rapport with the patient. As sir rightly said, you will discuss with the patient, you will picturize the things, you can draw a diagram. But if there is a trust issue, so you will not connect with the patient from patient side. This patient needs always assurance. Yes, ऐसा होता है. Then again they will ask the doubt. You have to clear them. And obviously, sir के पास नहीं हुआ, they will go to the another orthopedic surgeon and show the things. So they frequently changes doctors because they cannot trust anybody because of their paranoia. So though I am telling about the patient traits, it may be possible that relatives can also have such kind of trait which can impact the treatment. So another personality is a schizoid personality. These people are very reserved, less communicative. They are having get attached with others, understand the others' feeling. They are mostly they are self-absorbed, socially detached. Why it is important? Because there won't be a proactive discussion with the patient if the patient has a schizoid traits. Some patients are very impulsive, will say, yes, sir, go jao, kuch bhi karo. But at the same time, they are risk-taking. Usually, these are the patients who can see everybody will be in a white dress. They will come with the black kind of thing. So, in the way, they are like, they have antisocial elements in there. They like to break the rules and norms. Red signal hai, they will go ahead. They are impulsive in taking decisions. They love the risk-taking behavior. आपने बोला है कि नहीं liver का problem है, दारू मत पियो, they will do that. Don't engage in this maladaptive behavior, they will definitely do. Might be becomes offensive during your treatment, might be aggressive, express aggression towards you. They are less likely to follow treatment plan. They engages in substance, alcohol or cannabis use. And usually these are the male genders. So why it is important, even if you go to the treatment with the same treatment plan, with the same efforts, your effort may go waste because of their impulsive and risk-taking behavior. There are it is prominently seen in the female gender, that is a histrionic or neurotic traits. These people needs always attention. They want to be center of attention. They try so much thing or different thing to catch the attention of others. You might find it's a silly kind of gesture or behavior, but they will do that. They will have excessive concern about their self-image. And sometimes, they are saying, nahi doctor, khupos doko duktan. You are not find the expression of pain on their face. That we call it as the appearance is different and feeling is different. So we call it as in psychiatry, labella indifference. These people are pretty much preoccupied the thoughts related to illness, like a neurosis. They always keep on complaining the things, even if you find there is no severe organicity or organic problem is there, but still they will keep on complaining the things. They will have frequent visit to the doctors to catch the attention, and usually seen in the female gender. Why it is important? Because you cannot satisfy this kind of person. You have to understand that. You can do each and everything, but still they will be unsatisfied and complain the symptoms. There are few persons who might have a narcissistic traits. Do you know about this story about Narsi? Narsi was a king. At that time there was no mirrors. Once jungle में जाता है, then he sees water, lake में water दिखते हैं, and he sees his own face. So he falls in a love of himself, and he jumps to catch that face. So this is the narcissism, means these people are so much involved in themselves. They will not take a note of others. They like, always in discussion, I, me, myself, मी हे केलं, माझ्यासाठी असं आहे, माझं असं आहे. So there is always grandiosity in their talk. They feel each and everybody is inferior to them. They were never accept their errors. नहीं, मी तर चुकतच नाही. They try to teach you. Even your treatment plan, they will try to teach. नहीं, doctor, we can do this. ऐसा करना है, वैसा करना है. They are less likely to follow the advices because the self-love is so much. So these people are very egoistic and they need constant high praise. So if this kind of people come you and paying you, then it's good. Always keep on praising them. काम हो जाएगा. There are another personality which is prominently seen in a psychiatry because this patient creates a lot of problem in their relationship and at home. So these are the borderline traits. Why we call it as a borderline? Because they are not stable. Either they are in the border of psychosis or neurosis. They are very emotionally unstable. There are frequent mood swings. They are impulsive, dysphoric. And these kind of people never had a gray area in their life. Either Anish Bhatt is white or black. वो बुरा है, वो अच्छा है तो अच्छा है. And suddenly after 2 years, Anish Bhatt can become a good. But he might not be in a gray area. So always they are having two phases. Somebody is good or somebody is bad. And they can go to any extent for their emotional issues. Means usually you see impulsive teenagers, borderline personality girl, cutting their arms, coming to the casualty. So most of these having the unstable personality disorder. Why it is important? Because this personality is going to might create a lot of issue in private practice. If this is if this is a female and if treating doctor is a male, there might be many issues which we see in the today's practice. So we have to become little cautious about this because they might call you at the midnight, they might institute you and say that I am emotionally unstable, sir, बहुत खूब दुख रहा है, बहुत problem है, so immediately मिलना है. So be cautious about these personalities. There are few personalities which are very docile and seen in the maximum population. These are the avoidant and dependent personalities. Avoidant means they try to avoid each and every situation. कोई भी problem है तो avoid करो. They try to avoid to take decisions. Dependent personality, they are emotionally dependent for taking decisions on others. And these two personalities, traits, avoidant and dependent types of people needs constant assurance. So we have to understand this. If this kind of patient is there, so he or she is not a proper decision maker of the treatment plan, better to talk with some senior, close one family members and decide the treatment plan. This is very good trait as such, what we call it obsessive compulsive traits. Very famous personalities, popular, successful personalities have these traits, and it's very good for the progress. But it's very bad for the doctors when they come to you. They are very worst patient, I say, because they are very perfect, too much perfect. They are excessively obedient. They follow each and every, तुम्ही सांगितलं ना, you have to take this pill at 7:30 in the night at 7:30. They will, sharp 7:30, they will keep the alarm and take a pill. They overanalyze. They keep on analyze. They keep on, and if you ask them what happened, how you had this injury, so they are going to give us unnecessary circumstantial details. Like सकाळी 6 वाजता घरातून निघालो, ॲक्सिडेंट झालाय 10 वाजता. ते 4 तास यायलाच अर्धा तास लागतो त्याला. So they are very circumstantial because they concentrate on each and every minute details. So they keep records of each and everything. So it's become difficult. If you say ना की नहीं थोडं साखर खाल्ली तर चालेल, they will say नहीं doctor, you said that it's not allowed last time. So I wrote it down on the file. It's not allowed. So how you are saying now it's allowed? So it's become difficult to convince them. Because each and every recorded, they always carry diary, pen, and notebook along with that to note down each and everything. They sincerely follows instruction, and not only this patient, but they force family members also to follow the things. It's become very difficult to stay with the obsessive compulsive personality traits person. And these persons are really difficult to satisfy. Understand this kind of person, so you can keep a safe distance with them and do the treatment. There are other few traits, like some people are always depressive. They complain so much, negative attitude. Even if they feel better, they will never feel better. Even you can say that X-ray is no showing everything is clear, but they still there is a pain. So these are the depressive traits are there. There are some anxiety or anxious kind of person, which usually we see they are very excessive worries about their symptoms, preoccupied, anxious mood, always feel on the verge, feel discomforts, needs regular assurances, and there are some persons who are having passive aggressive traits. Means they passively agrees to everything what you say, but there is internal anger against you. So by the some they will do something that they will show that they are aggressive, but they say if you ask them, yes, yes sir, I will do that, but they never do. So these showing their aggression in a passive way is called as passive aggressive traits. So how to catch this is very difficult. I said that I know Ashish since 14, 15 years, so I can understand his personality. But we don't have that much time. But if you observe, if you be vigilant, communication, so definitely give the cues to you. If you see the interaction of patients with the family member, if somebody says ki nahi asach jhala pahiye, then point maybe he must be a dominating person, patient, or nahi doctor you decide, doctor she will decide. So there may be possibility that he may be avoidant or dependent kind of thing. If somebody has excessive, you say, attention seeking behavior, that is definitely can be captured. So, but you need to give enough time for that. What are the importance of psychological determinants? What we learn about the health belief, illness perception, defense mechanism, and lastly the personality traits, because these are important because it's needed for the acceptance of the diagnosis. Not only the diagnosis, but the acceptance for the treatment plan. It's important for the communication. It's important for establishing the rapport with the patient, rapport with the family members. It's important to understand these psychological determinants because there must be a good, trustworthy relationship between the client and doctor. If there are complications, because we know we are in a medical field, everything can be unexpectedly arise. Even we know, even normal seizure hota hai, it goes on, and suddenly you find there is a complication. If you understand the personality or psychological determinants, there may be possibility that you can handle the crisis of complications. You can predict the recovery. Yes, if the patient is obedient, soft, having maybe mild anxiety related to illness, but follows the treatment plan, there may be a good recovery, rather than if there is a risk-taking patient, there might not be that much good recovery. And it's important to understand the burnout, to avoid the burnout of ours. Because as a doctor, we give 100% to each and every patient, but results varies. And many times we say, we also say to the patient, ki nahi office ghari dokyat gheun jau naka. But it doesn't happen with the doctors. They carries complication, they carries the patient results, they have to be preoccupied, alert, vigilant about the patient they are treating. So there are possibilities that there is a burnout. Even if you are giving 100% to the borderline personality traits or antisocial personality traits, there might be not possibility that result will be there. You have to understand that. And definitely if you understand that, there will be a less burnout. What we can do, because we know we are having limited resources. I have seen that psychiatry OPD, there are a lot of patients, 15 patients are admitted. So we have limitations about the time, we are having busy schedules, at the same time we are having resources, manpower also, limitations of manpower. But there are some things, if you understand the psychological determinant, we can imply in our cabin. First is the sympathy and empathy. This is the very much important thing, because patient has come, maybe fracture, ulna, maybe the day-to-day kind of thing for you. Tuberculosis, hypertension, diabetes, may be a day-to-day kind of thing for a doctor, but it's happening first time in the patient's life. And he or she might not having the idea, whole knowledge about this. So if your patient comes and if you say that you are sincerely listening to the symptoms, to some extent like sympathizing with the patient, are re, ho ka? Oh re, changla nahi, but good. So if you active communication from your side, or at least appreciation through the simple words, may encourage patient to be a part of your treatment plan. Because डॉक्टरांना आमचं कळतं, that is important thing patient says, and sometimes you have to put yourself in patient's shoes and see the world. Like, you know, ka nahi baba, what I am saying that, but that lady is not following the treatment plan. What happening? Might be, if you see that, if you understand that she might be not the decision maker in the family, she sincerely wants to come to you, but there is financial issues, or family support is not there. So you have to be little bit sympathize and, if possible, in few of the cases, empathize. But always see that this should not be go to that extent that you cannot switch from empathy to the normal life. Because it may, if you go through the empathy continuously, it may cause a burnout in you. So what is important? Communication, yes. We have to open during our interview, open-mindedness, non-judgmental, not judging the patient immediately. It has to be a two-way communication. It's not something, nowadays, nothing like authoritative kind of doctor relationship. This is the area 3 to 4 decades ago. Doctor was a decision maker or authorized person who is going to decide. Now it's not like. हे मी सांगितलं तुम्ही का केलं नाही, it's not like of thing. आता भोगा तुमच्या कर्माचे फळं नाही. So these all words, we cannot be authorized nowadays. You have to be a two-way kind of thing. There has to be two-way communication. You have to be polite, but while polite, you have to be professional also. Because sometimes patient can take undue advantage of your politeness. So sometimes you have to keep the boundaries between you and patient in some way. Otherwise, they will keep calling you, they will keep messaging you, WhatsApp, or they will follow on Insta. So each and everything, because patient says, Doctor, तुम्ही कुठं जैसलमेरला जाऊन आले का? Because they see the videos. So always see, you have to give a satisfactory time, but it is also important, the patient should be satisfied. The communication, try to, if in many times it happens, satisfaction cannot be a term, very vague term. Patient never can become satisfied. Many patients, if they are obsessive compulsive traits. So for those patients, you have to have a discussion which has to be very focused, problem oriented, and very specific. During the communication, while listening the things, as sir rightly said, that I will sit with the patient, I will make a treatment plan, but I will explain the treatment plan to patient also. So it's important because he should be, or she, or the family should be engaged in the treatment plan. Motivation, very important. Try to motivate the patient, try to praise the patient, appreciates if you see some efforts patient is taking, because it will create a positive vibe in your cabin and it will give positive vibes to the patient also. Because I do remember my aunt is going through CA breast therapy, chemotherapy. So after 4 cycles, doctor came to her because she almost lost her courage. And just he came and पाठीवरती थाप मारली, you are doing great. So she felt, there is some kind of motivated doctor has given to me. Then definitely that motivated her. Then I requested doctor, sir, 2 minutes फक्त every time when she comes to the cycle, फक्त take a round of 2 minutes and say that she is doing great. So all your words, even you say, sometimes patient comes to you after 10 years, 5 years, usually in the psychiatry, Ashish and Anish must be knowing. And they said, the doctor, oh, jab aapne bola tha na, that changed my life. Abhi, we don't remember all these things because us waqt kya bola hoga. And there are simple words like, you can do that. Yes, situation is difficult, but I know that you are so brave that you can do the things. So little appreciations, little praising in a positive way, boosting their efforts will definitely sustain their motivation and they will strictly, sincerely follow your treatment plan. Psychotherapy is very advanced, very intense kind of therapy. but there is something called as a supportive therapy. So these are the brief supportive interactions with the patient you can have in your cabin or in your hospital. These are like provide emotional support, validation, appreciation, saying yes, you are doing well, giving some practical coping skills like minor advices, not only about the illness but other problems, reassurances, encouraging them, and help them to manage the stress and their symptoms. Definitely the supportive psychotherapy, and usually I know most of us, almost all of us are do with the patient. Encourage patient to follow the adaptive behavior. Change the lifestyle, important if there is a chronic illness, regular exercise, yoga, meditation, scheduling and prioritize your things to avoid the stress, and strictly avoid the maladaptive behavior like use of drugs, alcohol. So simple way we can have a communication, we can talk with the patient about the daily living skills, we can ask them to be expressive, we can discuss the domestic and community or personal issues with the patient, and try to motivate patient to socialize. So these are the adaptive behavior we are suggesting to the patient, and try strictly saying no to the maladaptive behavior. This area which I am seeing since introducing, I visited the temple. It's a beautiful temple, they being there. Friends, religion and spirituality is important aspect of our lives. And many cases, if you see, even we, when medical field, we cannot do that much. We are incapable to give. But faith in some philosophy, faith in some Hinduism, Islamism, Christianity, so that can give the motivation and inspiration to the patient and determine his or her his psychology to fight with the patient, especially chronic deteriorating cases. But while doing all these things in our small cabins, there is something or some end comes, we have to refer patient to the experts, psychiatrist. When to refer? If patient has pre-existing psychiatric morbidity like depression, anxiety, schizophrenia, and high chances that psychiatric condition might affect your treatment plan. For example, patient is having the history of schizophrenia, and because of illness he is not following your treatment plan, please refer to the psychiatrist. If patient is already going through the major depressive disorder or anxiety, generalized anxiety, panic attack, and many times you get confused whether it is a panic or it is really a organic kind of thing, if do refer to the psychiatrist. Few times pre-existing psychiatric morbidity means the pre-existing psychiatric morbidity can cause problem in the trouble in the treatment plan, but due to illness, new condition, medical condition, underlying psychiatric condition can be exacerbated. Like somebody is going through a depression and suddenly something comes. Obviously, that might trigger the recovered depressive symptoms also. And the depression, anxiety, these are the very common psychiatric illnesses and can be secondary to the medical condition. If you say the post-stroke depression we call, post-viral depression, post-delivery depression or postpartum depression, so even the general medical condition can secondary give rise to the psychiatric condition. At that time, you have to refer to the psychiatrist. But how to find out? If during your treatment plan, even you are discussing your follow-ups, if you find patient is very much depressive, very much negative, talks only the negative things, and feels that he or she could not overcome the illness, that may be the indication. You have to refer to the psychiatrist. If you ask patient, simple patient, झोप येते का? No, नहीं डॉक्टर, बहुत सारे विचार चलते हैं दिमाग में, नींद नहीं आती. So this biological rhythm, disturbed biological rhythm like decreased sleep, decreased appetite, might be an indication of psychiatric illness underlying. If there is an excessive concern, patient keeps on repeating the same things, even not getting satisfied by your counseling, or patient might be too much anxious. If patient is having some belief like, nahi, if there is a pain in the chest, definitely I am having some heart condition, that is hypochondriasis, which you feel. So these symptoms might be the indications when you have to be cautious and refer patient to the psychiatrist. Obviously, we know there are psychosomatic symptoms. Many patient comes with the hyperventilation. Many patient having hypertension, diabetes comes with the hyperventilation, and you find everything is normal, investigation normal. Even the symptoms are vague and unexplained. There are symptoms, but there is no organic cause. If patient is constantly calling you, coming to the clinic frequently without announcement, if there is a frequent visit, frequent change in the doctor, hospitals, institute, piling of the files, preoccupied with the medicines, morning ka ye 4 guli hai, dophar ka ye 4 guli hai. So these kind of things, these are the things which you find. If you find patient is constantly, you are observing in your cabin, then definitely refer to the psychiatrist. And there is, I always say, if you find any patient difficult, na refer to psychiatrist. Ab zyada socho mat. And then if you refer patient to the Ashish or Anish, Ashish means Ashish Square, both. So what they do the detailed analysis and evaluation. They take beautifully way history, resident must be knowing. After evaluation, they formulate the diagnosis. They understand determinants like biological, psychological, and social. They assess the personality. They observe the personality by the history and by the behavior. If there is no specific cue, they go for the psychometric analysis. These are some psychological tests they apply. They cater the personalized treatment plan according to the personality and psychosocial determinants. They go for the pharmacotherapy. If there is a depression, anxiety, there are definitely, we know, yesterday also we learned there may be some chemical changes, some disturbances in the brain that constant stress can cause. So for them, antidepressant, anxiolytic drugs, even benzodiazepines sometimes. Even if patient is having mood swing, then mood stabilizer. So all the pharmacotherapy they can use. They will, if they find it is important, the patient is needed more than some supportive psychotherapy, they refer to the psychologist, or they can do the psychotherapy like cognitive behavior therapy and rationalized emotive behavior therapy. They involve family and family members during the treatment, because if they involve these things, definitely the positiveness will be found on the medical condition also. And obviously what we learn, they go for the lifestyle modification. Of course, as I said, if you find anything difficult, anything problematic, we are having beautiful team here. There are handsome psychiatrists available next door. So young, enthusiastic team is there. Please refer to them. Thank you.
Thank you for a very interesting talk, sir. We know that psychiatry is very fascinating branch, and this is the reason why everybody likes to continue to listen to such interesting points. Are there any questions from the audience? Maybe sir can take a few of them.
I forgot to mention, in your personal life also have a psychiatrist as a friend.
I think we should make friends with you. Sir, I've heard that cognitive behavioral therapy is doing great strides in tinnitus and psychosomatic illnesses. What's your take on personality disorder?
Personality disorder is a totally, what we are discussing is just personality traits. This personality disorder is a totally different domain. And where we sincerely as a psychiatrist find that pharmacotherapy has a very little role. More of the intense psychotherapy, like as you said, REBT or CBT, definitely have a great role in that.
According to you, every personality is some having traits, as I explained. Everybody has one of those. People are, obsessed with cleaning their houses. That means they're obsessive personality. They're obsessed with studying, obsessive personality. So everybody has one of the other traits. Can you even call them disorders?
Sir, even when we learn during our PG about this topic, personality disorder, next time I personally go through the retrospective in my life. I diagnose at some time, yes, I was borderline. Yes, I was having some risk-taking behavior during college life. So, but these are the traits, sir. When we call in psychiatry, it's very beautiful. We never call disease. We call disorder. Why disorder? Because things are not in order. So this is disorder. We are not labeling somebody having a schizophrenia as a disease. We are saying schizophrenia as a disorder. Second thing important, in any way we are having, you might be concerned like, if Anish diagnoses depression sitting in the Mayapur, if the same patient comes to me in my private clinic, so I also will diagnose him as a depression, major depressive disorder, because we are having specific diagnostic formulation, which we follow. That is a DSM-4, DSM-5 now, that is Diagnostic Systematic Manual of Diagnosis. And second is ICD-10 and ICD-11. This is very specific diagnoses are there. And in psychiatry, unless and until, even I may have some traits, I may have some symptoms, but unless and until, if my life is not impaired because of that and it's affecting my day-to-day life, then only we call it as a disorder. Because everybody has this very personality. If somebody is dominating, somebody is having obsessive compulsive, it's their characteristics. If you see in most of the traits, these traits can be utilized in a very positive way in your treatment also. So unless and until if there is impairment in day-to-day life because of these traits, or you are creating lot of issues with others' life, in others' life, then only we call it as a disorder.
Thank you, sir. I'm sure many of the audience must be also having some questions, but we can, and I request Aparna madam to go ahead with the next talk.
The very inspiring talk and explaining different traits and the importance of requesting Dr. Darpan Mahesh Gauri sir to kindly felicitate our guest, Dr. Dhananjay Ashrut.
And secondly, I will say that the gift I received, that is the Bhagavad Gita, is one of the best counseling manual, and many times we implement in the psychotherapy of the concepts of the Gita and the questions which Arjuna asked to the Sri Krishna and answers given by. Thank you.
We proceed with the next guest lecture, that is Artificial Intelligence in Drug Development by my colleague, Dr. Deepak Langde. We did MD together in VJ Medical College, requesting Deepak to come on the stage. I request Dr. Santosh Kumar Rajmani sir to introduce our guest speaker, Dr. Deepak Lang.
Very good morning. I would like to introduce Dr. Deepak Kumar Langde sir, our honorary speaker. It's a privilege to introduce Dr. Langde, a distinguished clinical pharmacologist and an authority in biostatistics, pharmacovigilance and regulatory affairs with more than 27 years of rich professional experience spanning clinical research, medical writing, training, academic mentorship. Dr. Langde is an alumnus of Pune University, where he completed his MBBS in 1995 and went on to earn a PhD, MD in pharmacology in 1998, securing first rank and being awarded the prestigious late V.S. Sovani Medical Prize. Further strengthening his quantitative experience, he obtained a postgraduate diploma in applied statistics from Mumbai University in 2006. With an impressive portfolio of 145 national and international research publications, Dr. Langde has made sustained and meaningful contributions to medical research. He has served as ex-member of Medical Research Council DMER Maharashtra and as ex-faculty at MUHS in pharmaceutical sciences, shaping both policy and education. Dr. Langde is widely respected as a trainer in good clinical practices, new drugs and clinical trial rules of 2019 and ICMR guidelines in biomedical and health research. He is a much sought after consultant in clinical pharmacology, pharmacovigilance, biostatistics, and research ethics. He is known for his analytical rigor and clarity of thought. Dr. Langde brings rare ability to translate complex statistical concepts into meaningful clinical and research insights. His deep understanding of practical applications of statistics in biomedical research makes his guidance invaluable to clinicians, researchers, and students alike. We are truly honored to have Sir with us today. Please join me in extending a warm welcome to Dr. Deepak Kumar Langde, sir. And his topic is a favorite of mine, artificial intelligence in innovation, role of AI in next generation drug discovery. May I call upon Sir to deliver the talk.
Yes, thank you, sir, for an elaborate introduction, but I am actually your colleague, so nothing much. Anyways, so good afternoon to all. First of all, let me thank the organizers and Dr. Pentevar, Dr. Aparna, who is my colleague, dear colleague from BJ Medical College, for having me here for this very good activity, which is an annual activity. So I am privileged to have talk on this topic of AI in drug discovery. Okay. So just a disclaimer. I'm not an expert in AI, so I hope I don't get many questions at the end. And some contents of this presentation are made using AI. So in this short session, it will be a short session because I know I will not stand between your lunch, because after this you have a lunch. So I will not come into it, you will interfere with your lunch. So we'll discuss about the understanding of AI, how we can use AI in a drug development process. Also explore, I was told, because this also involves orthopedics and dermatology, so we'll have some examples of how we can use AI in these domains, and then discuss the impact of AI on clinical practice per se and the future directions. So why drug development requires AI? We all know that drug development is a very lengthy process. We have been teaching that in the undergraduate pharmacology also, and it could take decades. Even 7 to 10 years is the average time required for a new drug to come into market. Plus, it has a huge cost involved to the extent of 2 to 3 billion per drug molecule. And that's the reason why, because of the lengthy period and the cost involved in the research of new drugs, we need to have advanced tools so as to minimize the time as well as the efforts for developing new drugs. So therefore, AI can definitely help accelerate every stage of drug development process so as to have quicker drugs in the practice. Before 2000, in the 20th century, most of the drug development was, as we know it, accidentally penicillin was found, and then we made use of it. Plus, we have other forms in like cinchona bark, how malaria was treated using the bark of a tree. And there are so many examples where serendipity has been involved in drug discovery in the 20th century and before that. But in 21st century, things have changed. And a lot of that has happened because of the advancement in the biotechnology, advancement of computing, advanced computing, mega computing. Because of that, there's a development, the change in the development pattern of drug discovery nowadays. We all also know about these common examples of how serendipity was earlier used, but we add to that and we modulate that serendipity to make use of some advanced computing in the drug development process. So just I'll go into a bit about the process of drug development. As we all know, right from the identification of the target for a drug, we try to explore the different chemicals. Like in India, we have a lot of Ayurveda preparations, herbal extracts which we use, but they are not documented. There's no evidence for their efficacy and safety. So that's what the Western community says. So we try to generate evidence and try to conduct clinical trials and see whether they are good or not, whether they're effective or not. So a drug development process usually is right from discovery of the molecule, testing that molecule in vitro, in laboratory, see their pharmacokinetic profile, pharmacodynamic profile in animals, see the efficacy and safety in the animals, and then we go for clinical development, which again goes through phase 1, phase 2, and phase 3. And after phase 3, the drug is finally marketed and it's available for human consumption. And this entire process takes approximately 6 to 15 years, or in some cases even 15 years, some cases 7 to 8 years. So it's a very lengthy process. And when we talk of the target hitting, how much accuracy or what is the efficacy rate or outcome rate of drug research, it's 1 in 10,000. What does it mean? It means that when we screen 10,000 molecules, chemicals, for a prospective new drug, only one comes in the market. So failure rate is so high, huge failure rate. At every stage of drug development process, the drugs compounds they drop out because of lack of efficacy or because of toxic effects. So therefore, we need to screen multiple molecules so as to finally come out with a single molecule which can be finally used in humans. Take the example of COVID-19 vaccine. It's a recent example, everybody knows that. Now we have seen that drug development takes almost 10 to 15 years. What happened with COVID vaccine? So if you remember COVID, the first time COVID was identified somewhere in November 2019, and the genetic sequence of COVID was published in 2020 January. That's beginning of 2020. And the early clinical trials started in March 2020. So imagine the time, within 3 months of publication of the genetic sequence of COVID virus, a vaccine was available for testing in humans. So what does it say? It says that because of advanced computing, because of AI use, we are able to develop a vaccine within 3 months after identification of the target. And hence, further this went into phase 2, phase 3, and finally in the October-November 2020, the vaccine was approved for use by the US and the Europe. So what is the time period for all this? It was only 12 months. Why this was possible? Because at every stage of development of this vaccine, there was involvement of computing, proteomics, genomics, and advanced AI tools. And that impact AI has brought into drug discovery process. It's a huge impact. Right from 10 to 15 years, it has dropped down to 1 year. And this we have seen in the last 5 years. So therefore, what AI can do in drug discovery, it can help in the target identification, it can help in the designing of the drug based on the molecules available for the target or based on the chemical structure of the drugs, potential drugs. And of course, in practice, it can also help with prediction of clinical outcomes. So clinical prediction is the ultimate application of AI in healthcare practices. So to go in more details, we can have target identification and validation. Now we all know that if we have to discover a new drug, we have to first identify a target. Now, if those who are into medicine and diabetologists, you are aware that in the recent 10 years, a lot of new drugs have come for treatment of diabetes. Right? We have the recent ones, as we all know, GLP analogs, the big name nowadays, Ozempic, for weight loss and diabetes, or lifestyle disorders. All this is happening because of proper identification of potential targets for drugs to be used in therapy. And likewise, there's a huge potential for identification of new targets, especially for those areas where drugs are not yet available. Okay? So AI can definitely help in target identification. It can also help in drug screening. Like I said, 10,000 molecules, only one comes out. We can have AI modeling where we can identify the predictive, we can predict which drugs can possibly go to the clinical stage. So it can also be useful in the drug screening and lead discovery, plus optimization and design of entire drug development process, right from preclinical studies as well as clinical studies, it can be used. So in target identification, how can AI help? Because we all know how complex the genetic sequence is, or the genomics. It's very complex. It's a huge code. So simple computing will not help here. So we need to have advanced computing and AI models established which are able to diagnose and identify the data sets which are available for different diseases. This process, if you do it manually, can take years. But because of this AI modeling, we can do this in minutes and few hours. And there are many platforms available online also, where databases are available. Somebody, for example, if you want to do a research in, say, oncology, a specific particular, can say, colorectal carcinoma, you can identify the different genes which are expressed in the colon and which genes may be responsible for causing colorectal carcinoma. And that kind of advanced screening can happen with AI modeling. Plus, AI can also be useful in identification of the mechanism of the disease. Why does this disease happen? Why does diabetes happen? Why there is PCOS in young girls nowadays? So AI can also help in identification of the disease mechanism so as to identify the potential targets and finally address those targets for their final therapeutic use. Okay? And of course, AI helps in decreasing the time period for drug development, improves the speed and efficiency of the entire drug development process. Machine learning and deep learning is something which is, it always goes hand in hand with the AI. And we always say AI and ML, they go together. So machine learning is something which is useful because any kind of information about healthcare or human biology or healthcare data, it always changes. It is dynamic. Information which is available today may not be true tomorrow, or there could be addition of some information to the existing knowledge. So the AI tools, they have embedded machine learning which evolve over a period of time. Like all of you are aware of ChatGPT and Copilot, right? Many of us are using it in day-to-day life. Today, if you give the same prompt, and tomorrow if you give the same prompt to the ChatGPT, is the response same? It is never same. Because in one day, some additional information is uploaded by somebody on the web. So that's machine learning. Every day new information will be added, and therefore we have to evolve. We have to update our information, update our knowledge so as to help in development of new information and finally help in drug discovery. So that machine learning can be, of course, supervised or unsupervised. Unsupervised basically means that it's a self-explanatory phenomenon which happens without our knowledge. And then we can also have deep neural networks which are useful for drug development in AI. Now this term I came across first time when I was preparing the presentation. So something called as graph neural networks. Although I'm a pharmacologist, I never came across this word. But because of AI, I could understand that yes, AI has a very important role. Say for instance, this is a molecule. This is a protein structure. Suppose this is a target for our drug. So this protein structure is very difficult to understand. Even those in chemistry, biochemistry, molecular biology will have challenges in understanding this kind of structure. So what does AI do? It tries to break down this structure into more simpler matrix forms and finally simplify it for us to understand. And based on that, we can develop our new drugs. Like my colleagues in pharmacology know that we had something called as structure-activity relationship, SAR. We had in examinations, full question on that. So we used to relate a particular structure with some particular activity in humans. So likewise, understanding the structure of the targets helps us understand the drug development or identify the targets for our new drugs. Then we have something called as NLP, natural language processing. Of course, it is useful because nowadays much of information is gathered in the form of electronic health records, and this real-time data on information about the patients can definitely help gather more intelligence, more information, and help us develop new drugs. So NLP helps in multiple ways. I'll not go into more details of this. Generative AI is something which we can train the AI models to generate on itself without any input from anything else. We just give a prompt and the generative AI can definitely develop new molecules for drug discovery based on the protein structures or based on the channels, ion channels, receptors. They can develop new models. There's something called as high throughput screening, where a simple computer will give information about 10,000 molecules. Now AI has developed 10,000 molecules for a new drug, for example. We put that through this computer system, and within a few hours, it tells us which molecules are likely to have beneficial effect and which are likely to fail. So this again is a computerized system using AI, where we can screen multiple lakhs of molecules to get few molecules which could be potentially useful. That's what happened with COVID vaccine. We had the structure of the protein, and based on the structure, we had multiple molecules, and they were finally used for developing the vaccine. Multiomics is nothing but it's integration of different specialties for development of drug or drug discovery, where people from molecular biology, biochemistry, genomics, transcriptions, proteomics, metabolics, they can come together. In IT people, computer people, they come together and finally develop new drugs. Explainable AI is something which is going to be increasingly used, especially in conditions where we don't have any explanation for anything. Okay, say for example, psychiatric disorders, or where the outcomes cannot be explained. So AI models can be used to understand the basic mechanisms of outcomes. Why this particular thing is happening with this particular drug. In pharmacology, we commonly call it as idiopathic, right? So this kind of phenomenon where we can have no explanation, definitely AI can help us identify those phenomenon and help us understand in a better way. The multiple data sets are available online, and many of them are free also. For example, I come across certain platforms, like for example, this AlphaFold, it has a database of different genes or proteins, which anybody can download, and you can use it for your research. Okay? If a molecular biologist want to do some research on proteomics, they can do with the help of databases. So AlphaFold is one. Then we have this Benevolent, Recursion, then In Sitro, BioEdge. I came across all this in last 2 days. These are all platforms where data. Okay, very important in oncology. There's a lot of role of AI, because every day in the newspapers we read about how a particular gene is found to be responsible for a particular cancer. So this definitely AI models help us identify those genes, and those can be specifically target, and it can be used in therapy. Simple case study for genes. All of you are aware of BRCA genes, I think. Everybody is aware of, right? It is found to be associated, mutation of this gene is found to be associated with CA breast. And in fact, to the extent that, if you are aware, the case of Angelina Jolie, a Hollywood actress, she had her breast implants, and when she tested that she is positive for this gene expression, gene mutation, she removed the implants, and she even performed complete mastectomy, so that her risk of CA breast is minimized. Okay, so this is how this kind of information can help people have a better survival, better health outcomes. Okay, so different kinds of genes can be found out, and this is all through AI modeling. There are so many examples of cancers where we know that these kind of malignancies are associated with certain kinds of mutations in the genes. And knowing the mutations in the genes, we can target those genes specifically as targeted chemotherapy, or now what we call it as personalized therapy. Simple examples of this personalized therapy: we can have medullary thyroid with a gene, and then we have specific drugs. So depending on the target gene or oncogenes, we can have specifically prepare or design molecules targeted to those. And this is possible with AI within a short period of time. In orthopedics, we have cases like to identify the biomarkers which are responsible for causing the disease pathology, so that we can identify the disease early and have targeted therapy specifically for osteoarthritis. Similarly, in psychiatry, we still have a poor understanding about the neurochemistry or neurotransmitter release in the different parts of the brain, and understanding that in a better way will help us develop new drugs, especially antipsychotics, antidepressants, mood stabilizers, A lot of research is still required, yet to be done. We still are in the dark. All the drugs are there, but still we need to have better drugs than they are currently having in the practice. Okay? Like this, we already discussed how AI can help in designing a new molecule. Okay? Other interesting example is of personalized medicine. We are all aware of CAR-T cell therapy. It's again a very personalized medicine. We just take out the patient's blood sample, isolate the T cells, and then put something in the T cells, some genes or something, and specifically target a particular gene in the body. So this is more or less like a personalized therapy, individualized therapy based on the patient's own T cells. So this all is possible with because here again we need advanced computing processes. Okay? So there definitely AI has helped us a lot. Clinical prediction, yes, I discussed this earlier also. Now we can predict the outcomes depending on the available database. Okay? A lot of platforms are available, a lot of free apps are also available. Okay, what is the prediction? What is the likelihood of you getting a heart attack at the age of 50 years? What is your likelihood of you surviving 80 years of age? So those kind of modeling happens with AI-based algorithms. Okay, so prediction is very commonly used. In pharmacology, for preclinical testing of drugs in animals, we can definitely use them, and these algorithms can definitely predict the pharmacokinetic properties of the drugs. Okay, in fact, nowadays animal testing is going on decreasing, and we have so good algorithms that we can also predict what can be the half-life of the drug, what will be the plasma protein binding, will it suppress, will it inhibit any kind of enzymes in the liver. So those kind of predictions can happen with AI modeling. Other examples of AI in orthopedics, like we have newer bone regeneration agents which are currently under research. Currently we have very limited agents. So many new molecules are yet to come in practice. Research is going on that. Similarly, anti-inflammatory drugs for different inflammatory conditions. AI can also predict the response to biologics, because nowadays biologics is a term. When we talk of new drugs today, most of the 90% of the new drugs today are biologics. They are not pure chemicals, they are biologics. And we can actually predict whether this person is going to respond to this biologic therapy or not based on the AI modeling. In psychiatric discovery, again, we have different new antidepressants coming up, antipsychotics, which are still in research, and possibly they could come in this decade or next decade. Like CART therapy, we can also have personalized therapy in psychiatry, because every person is, in the earlier session we heard about how traits are there, personality traits are there. So different people respond to the same medication in a different way. So AI can actually predict what is the possibility or likelihood of this patient responding to, say, fluoxetine therapy or any other SSRI therapy or whatever therapy you're using. So prediction of clinical outcomes as well as prediction of resistance to any kind of therapy can be predicted using AI models. In clinical trials, we are already using AI and a lot of levels, right from designing of a protocol to patient recruitment strategies, in post-marketing surveillance. Most of the places we use AI tools. One interesting thing about AI is that they are commonly used for repurposing of the drugs. Okay, repurposing basically means what? We already have the drug, indication is there, but now we want to try this drug for a new indication, which could be better than the earlier. So it's basically nothing but new use for old drugs. Common examples are NSAIDs have been tried for depression, which could be caused because of chronic inflammation in the brain. Or one recent I heard about metformin to be tried in osteoarthritis or rheumatoid arthritis because of its anti-inflammatory properties. So these kind of repurposing is possible with AI modeling. So these are some examples of repurposing which we saw during COVID. Remdesivir, originally designed for Ebola virus, was widely used for COVID. Likewise, so many other drugs were used for COVID. That is repurposing of drugs. But of course, many of them failed, but still it is a good avenue for development of new drugs. Regulatory, I will not delve more into this because it's more of regulation and law. But yes, very important. As physicians, clinicians, your role is very important in AI-driven healthcare research. Because computers is a computer. You put something in, something is going to come out. What is important is that you need to interpret that, relate that clinically. See how important it is clinically. How does it relate with your patient? So clinical validation is very critical in AI modeling, and therefore we need to have data stewardship. Data stewardship basically means what? You need to share your data with everybody. So when everybody shares the data, we have more true database, real world data is available with us, which can be used for developing good AI models. Other example of developing of cartilage repair agents in orthopedics. Okay. Then we have new drugs which are addressing conditions like Alzheimer's disease, Parkinson's disease, multiple sclerosis. We don't have any good therapy for this, but now we have research coming up because of AI algorithms where they could be potentially beneficial to the patients. Okay, and of course, AI can be helpful in rare research. We call them as orphan drugs or orphan diseases. Okay, so any condition which is not very common, nobody wants to put money into that because there is no market. So their AI-driven research can definitely be helpful. Okay, this is just a snapshot of how the AI works. I'm not a technical guy, so I don't understand this. Okay, there are many challenges apart from the benefits. Okay, one thing is the data quality and availability because whoever is doing AI modeling, they don't have access to real-world data. Even if they have access to data, it is only for a limited sample, limited population, limited community, because nobody shares the data. Okay, so that's why I earlier said data stewardship. People should share data with everyone. There should be common platforms by the government where we share the real world data which could help develop good AI models. Plus, interpretability of AI models can be different. As I said, aaj jo daloge, answer alag aayega. Tomorrow if you put something, answer will be different. So reproducibility is not there, which is very important in research. Plus, there are many ethical concerns regarding sharing of personal data because genome data, gene data also is something very personal. So we need to have consent for that. Okay? There should be integration with clinical workflows. Data bias is a possibility because true data may not be captured. Validation and clinical translation also is a problem. So these are the challenges which we can overcome, of course. But yes, there's a good future for AI in drug discovery. We have already seen the benefits of that. And I'm sure in the coming decade and later on, a lot of developments are going to happen. And the only footfall of this is that, or drawback of this is that all the therapies are going to become very costly. Because personalized therapy, CAR cell therapy, individual therapy goes into crores. But they are highly effective. But the only problem is the cost. Okay, but yes, there's a huge future for AI-driven drug discovery. This is an article which I found when I was looking in the literature. And most of the content is from this article. I'll share this article with the organizers. You can have a look at the articles. Okay? So that was all which I wanted to share about AI in drug discovery. Thank you so much for being patient. We can take a few questions if time permits, but I'm not an expert in AI.
Thank you, sir, for the fantastic lecture. You gave a bird's eye view of the entire AI process of drug discovery. I just want to emphasize here that it took 30 years to determine the structure of insulin that AlphaFold can do just overnight. Sir, I had put a special slide because whoever is interested in AI research does have to know about AlphaFold. It's a magic because it helps you determine the protein structure overnight. Things which take 30 years can be done just in a matter of hours. And new molecules can be designed to that complementary domains. I think sir does a fantastic work and that slide was very nice. Can we have some other questions?
Yes, sir.
What is your view on that?
Yeah. I think I'll just repeat the question for everybody's benefit. He asked that because in the next decade, many new drugs are going to come based on the AI, and it will speed up the process of drug discovery for, especially in psychiatry, and how this is going to be beneficial in terms of safety as well as efficacy. Yes, definitely, sir. Based on the AI models, as I showed earlier also, we can predict efficacy. And as well as very important, as I said, different people have different personality traits or these. So we can predict which category of drugs could be beneficial in a particular set of patients. So it becomes more personalized therapy rather than a general therapy. Anybody with depression give fluoxetine. So that is not the case. We have to customize a tailor-made therapy for specific patients. So, and definitely, yes, safety is a very important issue because many psychiatric drugs used in psychiatry have a lot of adverse effects. In fact, some antidepressants themselves, they cause suicidal tendencies to that extent. So definitely, I'm sure that in the next decade, we are going to definitely looking forward for new drugs, which could be potentially safe as well as beneficial. But
one more question I
yes,
have. Sir, what is your opinion about AI in preventive medicine? Like now the Western world is moving towards more of a preventive medicine rather than just treating the illness. So what is your opinion about the AI in preventive medicine?
yeah, of course, I think if you look at the disease profile happening in our country or in the third world countries, the shift has changed from communicable diseases to non-communicable diseases. More of lifestyle disorders nowadays, and more awareness about lifestyle disorders, and improving the quality of lifestyle definitely is going to help towards it. AI can only help to understand people about the nuances of poor lifestyle or poor habits. Absolutely, yeah.
To get.
Correct. So there's a paucity of data. People don't share the data.
Don't share the data.
I remember in the last 4 years, I've received at least requests from 5 different companies, like Siemens and big companies, where they want to generate AI models to diagnose some psychiatric disorders based on the MRI of the brain. But people don't want to share the information.
Correct.
And whatever information they have, database, it's limited.
Yeah.
So unless there's a data stewardship and there's a database registries, which are freely available to researchers, then that would definitely come out with good models and good outcomes.
Yes. Thank you very much, sir. It was a wonderful lecture.
Thank you, sir.
Sir, drug discovery duration is decreased. So any change in the patent law?
Any change in the, sorry?
Patent law.
Sorry, I am not able to answer that because patent laws are different from drug regulations.
Because duration of drug discovery is 10 years, so they will keep the 20 years.
I am not aware of that, sir. I am not aware of that. Thank you.
This is not regarding drugs, but I am an orthopedic surgeon. So I want to know whether this new metal used in implants or design in the current nail, adding a screw, deleting a screw, or shifting the position, can all these be predicted with AI models for fracture fixation?
Like there is something called as fluid dynamics, wherever fluids come into. Likewise, mechanics are there, where AI can predict in this kind of injury or this kind of deformity, what kind of suture, nails, or what kind of device can be beneficial. So definitely there's a scope. It's a new avenue. I never thought of that, but it's something which can definitely be explored.
Thank you, sir.
Thank you.
Sir, what do you think is the role of data centers? And because we have such a vast continent, we have so much data in all our hospitals, but it's not being properly used, I think. Currently, as you said, all AI models are started for data, and we have so much data in every hospital, every patient. We are not just managing it and putting it in future, diverting it for AI. What is your take on that, sir?
See, data sharing has to be done. It's very important. As Sir has rightly pointed out, it's a huge country with huge number of patients, but data sharing is absolutely not. I'll give an example of COVID only. How many COVID publications came from India? Is anybody aware? Since 2020 to 2024, I think not more than 1,000. True. But if you look at the data from China or Europe, it's in lakhs. Just Google or PubMed or go to Web of Science or Clarivate, wherever you go, Elsevier, you'll find multiples of publications from China, Europe, and US. Why? Because they have something called networking. They have networks, and they prepare databases of registries. They prepare registries. Like all the COVID patients' data was collated at a single registry for Europe and China and US. And I am sitting in my room. I just thought, can HCQ be beneficial or not? Just a hypothetical question. And because I have the data, I simply apply my hypothesis to the data, take out the data, and do the analysis and publish a paper. That simple it is. So unless we have a data repository or registries, we cannot have good AI algorithms. But yes, there's a huge need for data sharing. Of course, we have to take into consideration the confidentiality laws or HIPAA guidelines what the US follow. And then Indians also have come up with a law which talks about patient confidentiality. So, but database is something which is a need of an hour. And the government should take up initiative for that. That's what is why I feel.
Well said, sir. Thank you.
Hello, sir.
Yes.
I'm orthopedic surgeon, Dr. Rajiv Munde. What is the role of AI in reading the X-ray and the CT and MRI? Because I have seen many applications of like that. What is your stand? How authentic it is? And is there any medical, legal or some legal aspect for that diagnosis with the AI for X-ray, MRI and CT scan?
Yes, as I said earlier also, because a lot of imaging companies like Siemens, Philips, they want to gather models wherein just put an MRI image, and a diagnosis will come up. Of course, it is going to be helpful, but human intelligence can never be surpassed. That is my take on that. It can be used to get some information, get some direction towards the diagnosis. But yes, human intelligence can never fail. I mean, it has to have. Humans have to make use of that AI for better patient outcomes. Like if you take example of ECGs, I think 2 decades back, we had ECGs with auto-reporting, right? ECGs came with a printout, the PR interval prolonged, possibility of T-wave inversion and those. But those diagnostics were not accurate. That again could be because of poor data, but now we have good data algorithms. So definitely AI is going to be helpful, but humans have to make better use of AI in the patient care. So that's what can be done. Okay, thank you so much. Thank you all.
Thank you, Deepak, for giving a great insight into emerging field of artificial intelligence in drug development. It will really help, I think, to reduce the animal toxicity studies, and thank you very much. I will request Dr. Santosh Kumar Rajmani, sir, to felicitate Dr. Deepak. We will like to felicitate our chairpersons. I will request Dr. Anish to felicitate Dr. Darpan Mahesh Gauri and Dr. Ganesh to felicitate Dr. Santosh Kumar. So requesting all delegates to join for a delicious lunch for the panel discussion.
Good afternoon, all. Welcome back after a good lunch. So we will be starting with a panel discussion session. For moderating this session, I would like to invite Dr. Anish Bhatt. As panelist, I would like to invite Dr. Shailesh Ratnaparki, sir. So you would please come on the stage, sir. Dr. Sushant Shinde, sir. Dr. Smita Panse, madam. And Dr. Ajit Dabholkar, sir. I request Dr. Anish Bhatt, sir, to please start up the session for the panel discussion. Thank you.
Thank you, Dr. Ashish. So, today I welcome you all for panel discussion session. Though it is a post-lunch session, we will try to make it more interesting and knowledge-filled. So, today we have dignitaries on dais and eminent speakers. They are very famous in all their fields. Everybody comes from different background of medicine, and we have very dynamic panel over here. So I hope our discussions will also be that much dynamic. So today I introduce you to our panel. We have Dr. Shailesh Ratnaparki, sir. I request, Dr. Shailesh Ratnaparki, sir. Sir is MS Orthopedics. He completed D Ortho also. He is a director of Suvidha Nursing Home, Akurdi. Consultant, Nirmaya Hospital, Chinchwad. Sir has passed MS in 1983 and worked under the great names in orthopedics like Dr. Nandu Loud and Dr. Ingal Halikar. Sir presented papers on open reduction and supracondylar fracture of humerus in IACON. Sir was the first president of Pimpri Chinchwad Orthopedic Association. So we have a very well experienced person in orthopedics to put light on the topic. As a second panelist, we have a special guest who is rheumatologist, Dr. Sushant Shinde, sir. He is MBBS, MD Medicine from AIIMS, New Delhi. He is EULAR certification. He has EULAR certification in rheumatology. He is a practicing rheumatologist and has a clinic at Dadar, Goregaon, Dombivli. He is also a medical medical educator and director of Quest Medical Academy, Mumbai and Pune. And you should know this, he is a TEDx speaker and he is a celebrated speaker for Charge and Care Paradox. Ram Vardayani Health Foundation, Prerna Prakalp. He is an avid clinical researcher and faculty at multiple national and international rheumatology conferences. So I welcome you, sir. So we have our third guest, physiotherapist, Dabholkar, sir. He is professor and head of sports physiotherapy in School of Physiotherapy, D.Y. Patil University, Nerul, Mumbai. He is graduate from St. G.S. Medical College and postgraduate from TN Medical College. He is PhD in physiotherapy and a GSMC Famer Fellow and Facilitator. He has 21 years of rich experience in academic research and clinical education. He is the postgraduate guide, PhD guide, and member of Board of Studies of various universities. He has been recipient of IAP Oration Award and also been awarded for global contribution in sports physiotherapy and been resource person in prestigious Athens shoulder course twice. Recently, he has published book chapter in international book on sports injuries, prevention, diagnosis, treatment, and rehabilitation. He has won many awards for his scientific presentations and has authored book chapters in national international books, published articles in journals of repute. His research interest is upper extremity rehabilitation, educational research, clinical biomechanics. So I welcome you, sir. As a fourth panelist, we have esteemed psychiatrist, Dr. Smita Panse, madam, who is MD Psychiatry from BJMC, Pune. Madam is currently Associate Professor at PCMC's PGI Institute, YCM Hospital, Pimpri. She is instrumental in starting MD Psychiatry in the first postgraduate medical institute in Maharashtra. She was a past president of Pune Psychiatric Association for year 2022 and 23. She was a convener, IPS Women's Mental Health Specialty Section 2025. She has a postgraduate teaching experience of more than 20 years. She has nearly 20 publications in the index journals. Her areas of interest is postgraduate teaching, stress management, consultation license psychiatry, and forensic psychiatry. Welcome you, ma'am. So we have our panel, whom I just introduced, and they are knowledgeable in their own fields. So we are today's theme for our panel discussion is from inflammation to recovery, okay, in the rheumatoid arthritis. So RA care today demands more than treating just inflammation. It requires us to understand how pain shapes behavior and how chronic inflammation affects mental health and how rehabilitation determines long-term quality of life. Our goal today is to break the boundaries and explore true interdisciplinary care. So with this theme, I would like to start panel discussion. I would like to ask panel experts, can you put some light on what does holistic care in RA mean from your specialty perspective?
Hello, yeah. Yeah, holistic care means actually an overall approach to every patient. I mean, I should not look at only the ESR and the other findings. I should be looking at the patient's mobility. I should be patient psychology when a person learns that he or she has got rheumatoid arthritis. It's a stigma in today's. I don't know how much it is today, but in my younger days, somebody getting rheumatoid arthritis was a stigma. In those days, whatever medications were available, whatever treatment was available, they would land up with multiple deformities of the hand, feet. They would land up with hip issues, spine issues. So if somebody contracted or was diagnosed with rheumatoid arthritis, it was like an end of their active life for them. So yes, it was a big stigma, and we needed to treat not only physically, but also psychologically, and of course the use of rheumatologists. In those days, there were no rheumatologists, unfortunately. We had to treat everything ourselves. We were the only holistic treaters. We had physiotherapists, of course, with us, but we didn't have the other help in those days. So yes, holistic approach is definitely necessary.
Please put your perspective.
So, as sir rightly said, rheumatology itself is a nascent field. It's an evolving field. In rheumatoid arthritis, is modern medicine in rheumatology. Today, no longer does a patient of rheumatoid arthritis need to undergo deformity or be on painkillers, or for that matter, be on long-term steroids also. Patients can go without steroids, without painkillers. This is the science aspect of it. But this is not what is available to our patients even today. Majority patients are still being treated in a very old-fashioned way So I think the first step in holistic management is getting the patient diagnosed right in time. So early diagnosis, early initiation of the right DMARDs. There is a lot of fear, and I should say this, a lot of fear amongst medical community about drugs like methotrexate, about drugs like biologics, which are common drugs today that rheumatologists would use, but doctors themselves are very, kind of inhibited because there is a stigma around these drugs itself. So I think the second step is early initiation of the right therapy, and then rehabilitation, which is missing. And the rehabilitation would have to be, I think as my next speakers would say, both physical as well as mental rehab. There is a lot of blame and shame that goes around rheumatoid. Very often we have to understand these are women who are at the receiving end socially also. They are very often married women with a lot of responsibilities which they are not able to keep up. So that brings a lot of pressure to these patients. And me taking care of just the joints is not going to be sufficient. Me just stopping the inflammation is not going to be sufficient. There is a lot of blame that the patient takes. उसकी सासू कहती है तुम्हारी तो उम्र नहीं हुई, तुम क्यों अभी आराम कर रही हो? This is something that needs to be broken. The idea that this is a disease of the young needs to be understood. And then the rehab, both physical as well as mental rehab, I think together, early diagnosis, early initiation of therapy, early and proper rehab, both physical and mental, would encompass the holistic care that we are talking about.
Thank you, sir. Before going to physiotherapist, I would like to ask psychiatrist about her view on this.
Hello, can you hear me? Okay. So it's wonderful to be a part of this panel where we are actually talking about holistic treatment for a chronic medical illness like rheumatoid arthritis, which is actually a disease which needs multidisciplinary management. So like all of us are aware about it, but we have limitations of our different practice. And now that science has progressed to the level that we can help out and we can have multidisciplinary clinics, mind-body connection has come to fore. Like the father of medicine, Hippocrates himself had told that every illness, mind affects the body and vice versa, body affects the mind. So the theory of 4 humors of melancholic, choleric or sanguine personalities, they predispose to different disorders, which goes with the Ayurvedic principles also. And coming now to the modern science, the father of psychosomatic medicine, Franz Alexander, also talked about it. You cannot just treat only joint or only liver or only brain. You have to treat the person. So here, rheumatoid arthritis is a disorder which affects the body, mind, and it actually impacts the person's personality, identity, his entire lifestyle. So we have to take into consideration all aspects of it, and for that we need collaboration between each other so that we are aware about the stage of the rheumatoid arthritis and the limitation of the flare-ups, and accordingly plan the rehabilitation.
So coming to rehabilitation, sir, what's your view on that? Am I audible?
So when it comes to holistic point of view, I would definitely say early identification, because that's the main goal over here. Early identification, if sometimes the patient may come to me directly, unknowingly, he may not know that he or she may have rheumatoid arthritis. And if I think that this patient needs a referral, so early identification, referral is extremely important. Also, when I say holistic point of view, I would like to emphasize here the biopsychosocial model, because there may be physical impairments, there may be a psychosocial aspect of pain, and therefore it may affect the social well-being. So all this comes to to a view that you need a multidisciplinary approach. It needs to be managed by as a team. So you need a rheumatologist, you need an orthopedician, you may need a hand therapist, and definitely occupational therapist to manage splinting. And therefore, if you identify where is the pendulum moving, whether there are psychosocial aspects of pain, then definitely we need to have a referral to a psychiatrist who can manage if there is an severe or moderate anxiety or depression.
Thank you very much, sir. So currently our all experts are on the same page, that we need a multidisciplinary approach. So with this note, let us dive more into rheumatoid arthritis and its pathophysiology, orthopedic aspect, rheumatologist aspect, psychiatric aspect, and also physiotherapeutic aspect. So I would like to ask Sushant sir, RA begins with inflammation but ends with disability. So if not addressed comprehensively, it causes a lot of pain and problems in the patients. Accelerates the inflammation and flares the RA, and how should clinicians screen for these factors?
Thank you, sir. That's an excellent question because there's a lot of work happening on this idea. The exact cause of rheumatoid arthritis, as we understand, is not known, but the risk factors are known. The top emerging risk factor today is actually air pollution. It's not the exact topic I'm talking on, but we need to be aware of this. We are seeing a huge rise in rheumatoid across cities. So many patients tell me, when we are in the city, we are bad. हम गाँव चले जाते तो ठीक होते. So there's a huge aspect there. And close second is stress, which again we see is exploding in the urban lifestyle. So a lot of patients, a lot of people who go through period of stress, and this stress, sometimes it could be a stress of maybe the patient got hospitalized for some period for some other disease, maybe fever, maybe a major surgery. Sometimes it could be a financial stress, patient has gone through, the family has gone through a stress. We very often find where the patient, when the first time they come to be diagnosed as RA, stressful period in their life. Add to that, we also see once we have started treatment, a patient who is successfully brought in remission, if he or she, usually she, because it's a female predominant disease, again goes through a period of stress, there is a flare-up that we expect. I'll add a small point here. There is a brother of rheumatoid called psoriatic arthritis. That's even more sensitive to stress compared to rheumatoid. Psoriatic arthritis is even worse. Even slight increase in stress and the patients will have psoriasis and will come back with arthritis. But yes, this brain immunology connect, the neuroinflammatory connect, is an absolute real thing. I'll add one more step to this, and this is where I think our maximum overlap with our psychiatric colleague comes. And that's the overlap of rheumatoid arthritis with what is known as fibromyalgia. And now there is very clear evidence that there is this idea of nociplastic pain. Nociplastic pain is when the brain is modulating pain. The brain is amplifying the pain that is coming from the periphery, and it's a to and fro signal. The brain in its higher centers is amplifying pain, and the nerves in where the pain is starting, they are amplifying the inflammation over there. So the brain has the capacity not just to stop the pain, but also to amplify the pain. And a lot of patients in chronic pain go through that cycle, and it's a repeated cycle. So we have to act at multiple levels. Just stopping the chemical aspect of inflammation, which is what our drugs would do, is not sufficient unless we take care of the other aspect.
So psychological aspect is much more important also in rheumatoid arthritis.
Absolutely.
Sir, I would like to ask you another question. What about the disease modifying agents used in rheumatoid arthritis, and how effective they are, and how they improve the prognosis in the patient of rheumatoid arthritis?
Okay, so I'd say there are three questions here, sir. First, disease modifying drugs, they are the standard of care today. Just a quick orientation, because there has been an explosion of drugs. Last 10 years to 15 years, we have a lot of new drugs coming up in rheumatology. So we can broadly say our drugs are of three groups. We have the older disease modifying drugs. To name a few, are methotrexate, which is still the leading drug, leflunomide, sulfasalazine, hydroxychloroquine. These are our older drugs. Then we have the newer groups, within which I will broadly make two groups. There is a big group called JAK inhibitors. JAK inhibitors inhibit the Janus kinase molecule, which is the secondary messenger at cells where inflammation is happening. And it stops inflammation very effectively. Some of the drugs there are tofacitinib, and now we have baricitinib. We also have upadacitinib, which has launched in India just 1 month back. There is a third big group, which is fantastic, but it is expensive, so a lot of our patients don't still get it. That is called the biologic group, where we can target the actual molecule, the secondary messengers, as well as the cytokines which are causing inflammation. And that's the big biologic group. There are multiple drugs within that. So we have three groups at our disposal. I will broadly tell you, 60% patients can be fine with just the basic drugs. The remaining 40 can get out of that, probably the 20-30 can get better with JAK inhibitors, and last 10% maybe are going to require balance. None of this is steroids. None of this is painkillers. And with this, most of our patients can achieve low disease activity, which means the patient is pain-free, the patient does not have a swollen joint, the patient, even if I press the joint, doesn't have pain. This can be achieved within 4 to 6 months. And it is absolutely possible to get the patient pain-free within 4 to 6 months. It won't be possible tomorrow. I'm talking without pain. That's the first part. There are drugs. Second, what's the impact of these drugs? Depends on when I start treatment. If I start treatment within first 6 months of diagnosis, that's the phase we call early RA. If a treatment is started in the first 6 months, the chances that the patient will have deformity is close to zero. Of course, there are going to be those patients who have very aggressive disease right from the word go, but they are very few. So the era of deformities should be actually behind us if we start them on treatment within the first 6 months. There comes the problem. They're not reaching us in 6 months. They're coming to us after trying everything by second or third year. It's not unusual for me to see a patient in Mumbai where the patient has an access to healthcare to come after 5-10 years of RA to first time be started on methotrexate. This is actually sad, but this is what is still the situation. So science will tell us we can get them right. Practically, we are not getting the patient. And third, can we prevent the deformities and improve the quality of life? Absolutely, yes. Patients can go pain-free. They can resume their quality of life. They can do almost everything that they wanted to do in their life. RA will usually not cause a limitation to their lifestyle or their length of life if managed well.
With this, how you manage the realistic expectation of the patient? Like patient wants quick relief and realistically it is not possible. So how do you manage in clinical practice to balance this both? Expectation of quick relief and timeline for disease modification.
Again, thank you, sir. That's again a very important question for our patients because they want quick relief. But I'll tell you, at least in my practice, I will say, and I can say this with some confidence for all rheumatologists, because patients come late to us, they've already spent, as I said, now years before they come to us. So now I don't think they come to us for quick relief. They want a permanent relief. And the trade-off, it's largely going to be counseling. We'll have to talk to them. The trade-off that I often discuss with my patients is you will have to choose. You want me to give you quick relief? The only way out is painkillers and steroids. But if you want me to give you a permanent, long-lasting remission, then give us time. And if put this way, after having suffered for months, most patients and their families are realistically accepting. So setting the expectations right matters. And for that, one of the important tools we have is to stage the disease. We would stage the disease as using the clinical criteria, depending on the joint, depending on the inflammatory markers. Is it low disease, moderate disease, high disease? A moderate disease, I might be able to get in control within a month also. Maybe a short course of steroid might just do the magic. But high disease activity, I will tell them upfront 4 to 6 months, and also tell them upfront that the treatment is not going to stop very soon. Is the treatment going to be lifelong? That's the question. So more than immediate relief, they are bothered, ki, Acha, you'll get us in remission, will we be on drugs forever? That answer depends on how early. If we start the treatment within the first 6 months, there is at least some of these patients who might come on very minimum drugs or might get a chance to go off drugs. That's a very small chance, but it's possible. But once you have crossed 2 years of disease, we stopping the drugs is next to no. At least today's science does not give me that. Maybe in future we might, but today we don't have that possibility. But long term, they're not going to be on a lot of drugs, but that discussion is something I do on the first day. That you are expecting this treatment to go on for years, nothing short of 7 to 10 years, and with that you will get an excellent quality of life.
Thank you, sir, for putting that light on the topic. So there is a lot of psychological issues involved in the rheumatoid arthritis care. I would like to ask Dr. Smita, madam, up to half of the rheumatoid patients suffer from depression and anxiety, that is what's said. So could you explain how chronic inflammation interact with brain's pathway and why RA patients are uniquely vulnerable to mental health conditions?
I think the rheumatologist has spoken that there is no exact mechanism or exact cause for chronic medical illness like rheumatoid arthritis. So therefore, the rheumatoid arthritis patients are affected by the biological, psychological and the social stressors that are happening in their life. Biological part that happens at the level of inflammation. So actually inflammation happens also due to depression. So depression can lead to flare-up of the arthritis. So it is kind of two-way pathway. Like the psychiatric disorders lead to inflammation, which can flare up arthritis. Arthritis itself causes inflammation, neuroinflammation, where various areas of brain are affected and the neurotransmitters are affected. So there is basically neuroimmunal crosstalk happening at the brain level. Like Sir has explained about how there is central pain sensitization. There is increased pain. So here, why do we need to treat the psychological part is because depression increases pain perception and anxiety leads to pain anticipation. So you have more anticipatory anxiety leads to more pain and secondary hyperarousal symptoms and morbidity. So whenever a person is diagnosed with any major medical illness like rheumatoid arthritis, he goes through an adjustment period and has various reactions like initial fear, then denial, then anger, bargaining, that why me? And finally, after going through the grief, he may come to a level of acceptance. Okay, this is the disease, I need to work with the doctor if they have landed with the proper person, or they may have to suffer more. So that is there. Then if that is not treated and there are other aspects like the financial strains or they have poor social support, then that also leads to long-term anxiety or depression. Like you said, almost 30 to 60% of rheumatoid arthritis patients have psychiatric disorders. So, and beyond anxiety and depression, they also have a lot of sleep issues and cognitive problems. And that again is through the inflammatory pathways. Like because of the cytokines, there is increased interleukin level TNF alpha, which leads to neuroinflammation. It affects amygdala, prefrontal cortex. So there the mood swings occur and may lead to major disorders. Then like the DMRDs themselves have some side effects because it again is linked to the brain neurotransmitters. So it is a very linked disorder. The psychological, biological and the social aspects all need to be treated, and then only the person will be able to lead a complete normal life with the newer drugs and the rehabilitation. The joint part, I think the orthopedic
Psychoneuroimmunology becomes more relevant in this case in rheumatoid arthritis. So my next question goes to Dr. Shailesh Ratnaparki, sir. Sir, as sir said, after 2 years it causes nearly permanent disabilities. So how the biological therapy changed the indication, timing and outcomes of surgical intervention in RA?
Actually, today's drugs have drastically changed the responses that the patients are having. In the olden days, we used to land up with a lot of finger deformities, wrist deformities, the knee problems. I mean, I used to do synoectomies of the knee joint very regularly in the past. I don't remember having done in the last 10 years. So that's the paradigm shift that has occurred. So the surgical needs for managing rheumatoids are going down by the day. And it's only the neglected patients or the patients come very late that they may need kind of surgeries to correct whatever deformities or whatever pathologies they may have. I do have patients who came with gross synovitis of the knee and affected movements. We did a total synoectomy. You could see patches of enthesopathy also seen of the invasion in this thing, which we debrided. And today those patients are having full range of movement because we did the surgeries on time. So getting the surgery done on time is also equally important. And one point I want to elaborate about this is when you see a patient, when you treat a patient, you must read the patient. In this I'm taking about 40 years of experience of treating patients. You must read the patient. What the patient wants and what the patient has come for. Fortunately for me, after so many years, I can read the patient. I know what the patient has come for. So if the patient wants immediate relief not because of pain and this thing, maybe the psychological, like he said, daughter-in-law is getting pestered by her mother-in-law. Then maybe I'll start her on a steroid immediately so that she is at mental peace, so that she is ready to take the further line of treatment. So I would sort of stop and turn my treatment depending on the needs of each and individual patient. Yeah, I would do that. Though protocols are there, that's okay for US-based practice where they go more by the law. But here we do adjust our treatment as per the patient's need. That would be a right thing to do because I believe that getting the patient's faith in you that you are going to cure or make that patient better is the first thing that you should have. Then the patient follows everything, and then you get the desired.
So depending on the patient's need, we need to do the
I'm talking about the psychological and the day-to-day activity need.
Yes, sir. So it must be challenging after post-surgical period, the rehabilitation of RA patient. So what challenges exactly the patient faces and also the consultant faces?
One thing is hello. Yeah. The challenges we face is that the moment the surgery is done, the patient believes that everything is over. That's the first challenge. That is the first psychology that patients have. I've undergone a major surgery. I've done this. That means everything is normal. So now I should be able to do everything that I wanted to do after the surgery. That is the first thing. So the pre-surgery counseling is important to explain to the patient, okay, surgery is going to achieve X, Y, Z, and you require further treatment like physiotherapy is going to be needed, some medication will be required, some other things are going to be required to make you get back to your activities that you actually aim to reach. So that is the first challenge that is there. Second is during physiotherapy, and all physiotherapists will agree with me that there is a lot of pain. So that pain also needs to be taken care of. So that physiotherapists will counsel, but we need to add medicines, if necessary, some blocks, kind of things may be needed to be given to ensure that the patient is able to do proper things.
Sir, there is a lot of air about reconstructive surgeries in osteoarthritis. So what is the current scenario in the rheumatoid arthritis about the reconstructive surgeries?
The principles are the same. If the joint is beyond recovery by conservative means, they need surgery. But reconstructive surgery for osteoarthritis and reconstructive for rheumatoid arthritis or RA or autoimmune diseases is two different things. After osteoarthritis, patients have almost near full recovery. That's because they don't have any other local disease. The problem with rheumatoid or this thing is there is a local disease going on. You don't stop the disease. You just cure that part or you just treat that particular part. But the ongoing disease is going to be there. So the results are going to be lesser quality, lesser effective than.
So this thing may brings a lot of importance of rehabilitation. So Dr. Ajit sir, exercise is essential for every patient with the joint diseases. So what strategies help to build confidence and compliance with rehabilitation in both flare and remission phases in rheumatoid arthritis?
It's very important when you identify early rheumatoid arthritis, it's very important that the patient continues appropriate treatment. So there has to be a communication and shared decision making with the rheumatologist and other specialists. Also, I want to emphasize here what are the importance, we need to explain the patient that exercise is going to benefit them. It's not that exercise is going to deteriorate the condition. And exercise has been found to be having highest, recommendation, for beneficial in rheumatoid arthritis. And as a physiotherapist, I want to emphasize over here that we speak about FIT principles. So how frequently you should do exercise. So the first is F, that is the frequency of exercise. They have mentioned in the recommendations and the clinical practice guidelines, which were recent, and at least twice strengthening of hand strengthening exercise needs to be done. Then at least 30 minutes have to be emphasized, they have emphasized. Then intensity of exercise should be very low. Load should be monitored. Body weight should be, taken. And it should be low load. Time is, again, as I told you, aerobic exercise. Strengthening exercise with respect to 1 RM, we need to be around 50 to 60% of 1 RM. Or if it is not accustomed, it can be 40 to 50% of 1 RM. 2 to 4 sets. and repetition needs to be around 8 to 15 reps, and in between the sets there has to be around 30 seconds break. And type of exercise needs to be, when you are doing aerobic exercise, large muscle groups needs to be strengthened. You can use static cycling because it is takes up the weight. Aquatherapy have been found to be beneficial. And at the same time, there are a lot of evidences with respect to VR-based exercise, which helps in adherence, which helps in biofeedback. It is more of a, it is also a distraction strategy. So you decrease the patient's anxiety. At the same time, you get a wonderful, feedback. Engagement of exercise needs to be also is one of the important, coming up revelations in management of RA.
Sir, with a lot of exercise in prescription, as a RA patient always fears to do exercise because of a pain. So what strategies you use to improve the exercise adherence and confidence of the patient in the physiotherapy?
Patient education is extremely important. It is not that one point, contact and, the treatment is done. You need to explain the patient about the follow-up, adherence to the exercise regime, regular follow-up. At the same time, making him, you have to explain him that exercise is medicine, because exercise here is acting like an anti-inflammatory, similar like aerobic exercise. So we also work on psychosocial aspects, so giving relaxation exercises, working on their negative emotions, so making them resilient to treatment, reassurance, and also bringing back mindfulness, whether it is with respect to diet, whether it's respect to exercise. Wellness of the patient is extremely important. So right from self-management to well-being is a continuous continuum, and therefore that leads to better successful outcomes. That's very important.
Yes, sir. So physiotherapy can influence a lot in fatigue, mood, and even sleep of the patient. So does it also help in RA patient to improve these things?
Of course, yes. Because as sir rightly said and ma'am said, that it's a neuroimmune compromised patient, and aerobic exercise have been found to influence the and whenever you exercise, there is release of good hormones, which are dopamine and serotonin, which helps in being well-being. Okay, and at the same time, this has an influence on inflammatory markers, and that also influences sleep. It also reduces anxiety. At the same time, it also influences depression. So it's like I would say definitely put it into place that exercise is medicine, and that should be emphasized by all physiotherapists.
Maybe exercise also reduces the neuroinflammation and inflammation.
It does.
And so there is a lot of air about the digital things from after Digital India. So we are seeing digital yoga, you are seeing digital mindfulness. So what is the role of digital rehabilitation and telephysiotherapy, as patient cannot come very frequently to the physiotherapist clinic? So what is the role of digital rehabilitation and physiotherapy, telephysiotherapy?
The patient can be far away, and that can be a problem. That can be a barrier for treatment adherence and treatment continuation. So I think telephysiotherapy or telerehabilitation is a very good option. COVID has taught us how telephysiotherapy can work. We gave a lot of telephysiotherapy during the COVID times into multiple patients, and I think that's the reaching out to the patient when he needs a reassurance, when he needs that recovery process, and what not to do is extremely very important for the patient. The joint protection principle, simple hand exercise therapy can be explained easily on a digital platform, on a telephysiotherapy way. And at the same time, there are various apps which are available, which can be, utilized by the patient to monitor the recovery process. It can also monitor your sleep. It can monitor your fatigue levels, and it can also act like a pain diary for the patient. So all the multidimensional assessment of RA can be assessed by a simple app, and I think it's extremely important.
Thank you very much, sir. So, while diving into this topic, we got a lot of insight about how the rheumatoid arthritis play the role and how the rehabilitation through orthopedic intervention has its own limitations and benefits, and how the exercise brings wonders in the disease. Let's open up it more, sir. So I would like to ask Dr. Sushant, sir, where do you see communication gap between medicine, mental health, and rehabilitation?
So I think that's a crux of our current problem, the communication gaps. The biggest gap, as I see today, is probably at the level of our education. We were discussing around the time of lunch, how much weightage is given to orthopedics. It's probably some percentage of surgery. I said, rheumatology तो option में भी नहीं. So we are talking of a disease which 100 means in this auditorium there is a likelihood there is one person suffering from RA. That's what we are talking about. And our communication will only build up if our primary healthcare or our primary level of education talks about it. It's missing from our curriculum. I think the first gap is there. The second gap comes in the myths around RA and how much we as a community, the medical community, has reached out to solve them, and I think there is a huge gap. Starting from, as I earlier hinted, that a lot of families will blame the patient, there's a lot of stigma. So is not equal to it cannot be treated. But ये difference जो है कि cure versus treatment, the remission is possible, low disease activity is possible. This idea is missing from the general perception of the disease. So rheumatologists will talk about it. Many specialties don't believe कि ऐसा possible. It is very clearly possible. It's like the stigma that oncology carries. I think second number हम है. The stigma that we carry about rheumatoid and all the other diseases, SLE, etc. included. So the second level is what is possible in science and what our general public and our experts know. And then third is within our specialties, crosstalk, which I think is probably the least, because today, at least in my practice, I can say, I reach out to my physiotherapy colleagues, I reach out to my orthopedic colleagues, and they reach back to me whenever we have a patient where we need to work together. So the multidisciplinary discussion is happening. I think that's the least of our gap today. We were fast to bridge that up, and that's a good development. But reaching out to the patient and those gaps are still missing.
My question is to Dr. Shailesh Ratnaparkhi, sir. How can we create a practical shared care model in our whole busy clinics or hospitals for rheumatoid arthritis patient or even any other immunologically mediated arthritis patients?
Yeah, basically there's a need for patient education, society education. I mean, there should be more, let's say now there are a lot of podcasts and kind of things. So let's use the media, let's use the newer techniques to spread amongst people that yes, you can get an autoimmune disease, but as you rightly said, it's treatable, may not be curable. But not being curable and being treatable means that you can still live a pretty good quality life throughout your life with a good control of medicines, good control of whatever, some habits which are triggering, they can be avoided, good methods of good regular exercises, and keeping yourself mentally strong. You can continue to live a good life. I think that should come through the society. Every doctor cannot do that. A doctor will treat only a few number of people. Like for example, if I am a single practitioner, maybe I'll treat a few people, he'll treat a few people. But if it's rampant in the, like the stigma is rampant in the society, we need to get the stigma out first. And I think the social media is one of the beautiful tools that we have today. And maybe some good NGO or some good medical organization who wants to do social service should bring about this particular thing and put it across to the entire population, the entire community that yes, it is treatable, though not curable. And treatable means you can continue to, you can put examples, you can do so many more things to do that. I think that's necessary to bridge that gap that is very on.
As our topic goes, bridging gap between joint, mind, medicine in rheumatoid arthritis. Madam, what you feel that what should be the psychiatrist role in all these immunological mediated diseases which exaggerate with the my psychological stress? So how we should include, as a psychiatrist, how we should include in treatment of rheumatoid arthritis, immunological disorder with orthopedician.
Yes, I think all disorders, so psychiatrists cannot be everywhere. But everybody has their own disorders, chronic disorders, which are treatable but not curable. So for that, here the psychiatrist's central role is understanding the patient's subjective perception of the illness. What are his illness beliefs? For example, if he says this disorder is like a punishment to you, so he has lot of guilt feelings and hopelessness. Or he may say this rheumatoid arthritis is uncontrollable. So then there is hopelessness, or sometimes there is catastrophization. Okay, this is it, this is the end. Or sometimes there is clear-cut denial. No, this is just one of mild illness. I don't need to treat. Leads to poor treatment adherence. So this underlying belief, illness belief, that should be understood from the psychological perspective. Then also how the person is coping with the illness, whether it is adaptive or maladaptive. That is very simple in the sense, adaptive coping is when you accept the disease, they are willing to solve the problems and willing to take help. And that really needs to better prognosis, better outcomes. Whereas maladaptive will be basic denial, it is not a very major illness, or not willing to take physiotherapy, avoiding different treatments, because being afraid of it. Sometimes maladaptive can be excessive eating or substance use, excessive smoking, just dealing with the disorder by avoidance, using alcohol as an escape mechanism. So understanding these psychological basic reactions which are there will help the psychiatrist to plan various mindfulness-based therapies, cognitive behavior therapy wherever needed. So here we must understand what is a normal reaction to the illness versus what is the pathological psychiatric disorders, when to treat. Because as psychiatrists, we don't treat unless the illness is causing functional impairment or the emotional reaction is out of proportion to the disability. Then only we need to treat. Or basically there is suicidal ideation. That is one very important factor which we need to look for. So in a busy rheumatology practice, what they can do is they can use few screening tools like PHQ. They may be using PHQ-9 for screening of depression, GAD, generalized anxiety disorder 7. These are small questionnaires. Maybe the social worker or somebody allied can be trained. So if the cutoff score is met, please refer to psychiatrist. That's what I will say.
So maybe early inclusion of psychiatrists in the treatment of rheumatic arthritis patient can create wonders. So my question goes to Dr. Ajit sir. You get a lot of reference from orthopedician, rheumatologist about these kind of arthritis patients. So what tools or data helps you to coordinate better with them as a main therapist, physiotherapist in this case?
When we get reference from the rheumatologist, we of course evaluate the patient, and we emphasize on function, how to improvise on function. So there are a lot of outcome measures which we do evaluate, like the quick dash, disability of arm, shoulder, and hand. That's very important tool to screen and find out what are the functional impairments. And Michigan Hand Outcome Score. Then there are other outcome measures like the 6-minute walk test for functional capacity, sit to stand test. There may be there are other tests to evaluate quality of life, the RA quality of life scale, or the global quality of life scale. Then there are multiple scales which we also screen in pain. So we evaluate pain We know the importance that pain is multidimensional. So as Sir said, that the patient may be having, great remission of the symptoms, but pain is central. So there may be central sensitization. So we use a central sensitization inventory to identify this, whether this patient is having central sensitization, whether the patient has pain catastrophization, augmentation of, whether the patient has kinesiophobia. We use the Tampa scale of kinesiophobia. There are multiple fatigue scales which we use because fatigue is one of the important symptoms. Sleep can affect so many. Sleep is so underrated in today's scenario that sleep impacts everything, the whole system. So we use the Pittsburgh sleep quality of life, where we evaluate quantity and quality of sleep. So, and at the same time, we also, evaluate other components as well, extra-articular manifestations which are associated with rheumatoid arthritis. So with this, we get an overview of, what the patient is suffering from, and then we plan the management with respect to what needs to emphasize on, whether the pain is an issue, range of motion is an issue, whether there is a pain swelling, and therefore which function long-term goals.
Thank you very much, sir. So now we are at the end of this panel discussion. I would like to ask each panelist to briefly share one thing you wish every RA patient to know about treatment, mindset, and recovery. So, Dr. Shailesh Ratnapaki, sir, you first.
I already said what was in my mind, that yes, we need to inculcate in the patient's mind that this is treatable, though not curable, and that whatever he or she wants to undergo, he or she can continue to have in their life. So that is the thing that I think, and for that, my request to all the junior consultants is that please spend time with patients. But what is the big lacuna, this thing I wanted to add, that the lacuna, one big lacuna today is doctors are not spending adequate time with patients. That is the unfortunate part. They're not giving adequate time to the patient to answer all their queries or whatever doubts they may have. So we need to spend a little more time.
Dr. Sushant, sir, your views on this.
One thing I would want is, of course, that patients know that there is treatment available, as sir said. I think that's the only thing. Relatives ask, so it's typically this way. There's a Juganvaldi in the clinic. Patient has some questions, and after that gets over, the real question comes from the person who has come with her. Kabhi theek hone wale hai ki nahi? So I really hope that person, not the patient. The patient has some faith. It's the relatives. I hope they keep faith, and the way I tell my patients, and when I talk to other doctors also, when we do a lot of CMEs, I say this, that we don't tell a patient who has a heart attack ki tum kabhi theek nahi hone wale. We don't tell them. Let's be honest, we don't have a cure there. We have a very good treatment in patient who has had an MI. And there is actually 30% risk is going to die. That's statistics in 1 month, mortality of a first MI. And we never tell him that tum kabhi theek nahi hone wale. So I ask a lot of people, हमारे patient ने क्या बिगाड़ा कि उनको बोल देते हो कभी ठीक नहीं होने वाला. So I just hope that patients know that there is treatment available. Science has exploded on the options, just that they know about it.
I think the social awareness is what is the key. There's a lot of social awareness. So a lot of people are educated, they know what is going to be done, they know about angioplasty, they know about bypass surgery. So that's my point I was pointing out, that we need to have a social awareness.
Social awareness is very important. So your views on treatment, mindset, and recovery. What
I think
message you will give?
We love to talk about, pathomechanics of the RA deformities, and patients are paranoid to see, they have so much of fear. This is what is going to happen to me. And I think for that we need early diagnosis, early referral, and after early referral, reassurance, great recuperation, and better recovery for improving the quality of life. That's extremely important.
Your views, ma'am.
Yeah, I agree that early diagnosis, early treatment helps all disorders, including rheumatoid arthritis. And like we have seen, the biopsychosocial model So the psychological aspect from that point of view, diagnosing depression, anxiety, and not treating simply it as part of rheumatoid arthritis. It's a normal reaction. So knowing whether it is abnormal and it needs to be treated will actually help the treatment of rheumatoid arthritis. So that part I think needs to be highlighted, that all chronic medical illness should be screened regularly for psychiatric disorders.
So, with the views of panels, we have reached to the conclusion that joint, mind, and medicine can be bridged if we work together. So, patients should know about that treatment is there for RA. More social awareness about the rheumatoid arthritis and other autoimmune disorders is must, as we have social awareness about the myocardial infarction or heart diseases. Patient should also know that early availability of treatment, if he takes treatment early, he can get better results. There are respite strategies available, reconstruction is available. Physiotherapy has advanced a lot in this sense to monitor the treatment and also deliver the best treatment possible. And early intervention in psychological aspects is also important. Being a psychiatrist, I feel happy that psychiatry is involving everywhere. So the floor is open to audience questions. If any questions are there, we would like to take it. Please mention your name and also you are directing question to whom, that also you mention.
I'm Dr. Gauri Medkar. I'm pathologist. My question is to all the panelists. For most of the immunological disorders, including rheumatoid arthritis, the treatment line is many a times anti-inflammatory and steroid, and systemic delivery gives a lot of side effects. So are there any local drug delivery systems like patches available for rheumatoid arthritis?
Yes. Thank you for the question, ma'am. So I think within the question, I'll just break it into two halves. We have been talking about RA. So in RA, steroids are fast. The role is really gone behind. We are 1 decade back if we are using steroids now, more than a decade. Short course of steroid, the dose that we use in RA will not cause side effects. If we use it correctly, the dose is very minimal. There is a second part in rheumatology, connective tissue disease, which we were not talking about, but those are the big guns. That is where I am afraid of. Where SLE is the big one, and then we have others also like vasculitis. There, the drugs are toxic, and there, without those drugs, we are looking at mortality as an outcome. So really, there is a no-brainer there that it's a question of will the patient have some leukopenia or will the patient die of lupus nephritis. I will go for the saving the lupus nephritis. So the risk-benefit ratio of all of these has been well documented. I'm not saying our drugs are absolutely safe, but I'm just saying that RA is no longer a field where the drugs are so toxic that they are going to cause side effects. Majority of our patients, if they are giving the drugs in the right dose and monitor, that's where it's a long journey. Majority patients will not have any major toxicity. And I can say, I'm saying this on the stage because this needs to be heard, I think, that it's not really true that RA medicines are toxic. They can have toxicity as much as we can say about probably anti-epileptics or any other drug. CTDs, yes, that's where the big guns are. But there we are dealing with a life and death situation. If I'm dealing with an aggressive ILD, interstitial lung disease, or aggressive lupus nephritis, or maybe a catastrophic APLA, I will have to give the big guns. And then again, we will try to optimize the duration to the shortest possible. Now coming to the local therapy, that is also possible. For example, when we get patients who have, let's say, 1 or 2 joints involved coming back to RA, instead of escalating the patient's treatment systemically, we can deliver the drug in the joint. A single shot of steroid will have no systemic side effects. It's actually very well tolerated. A lot of orthopedicians, a lot of rheumatologists do that very frequently, and that solves the problem. But giving topical anti-inflammatory, we don't have that.
Yeah. The second question.
So Dr. Ganesh, Professor and HOD Pharmacology. Continuation of our
So can you be a
discussions.
little bit louder?
Most of the immunomodulators are used for the treatment of RA and having the adverse effects. So adverse effects are more. So that's why the patient are comparing our allopathic treatment with the Ayurvedic and homeopathy. So the competition between all the other pathies versus our allopathic treatment.
So, this is a question which at least 2 out of 3 patients will ask me. What if we try some XYZ other alternative form of medicine? My first answer is, I am not an expert in them. So I have no comments. I have no comments on what happens in the other pathies. I am not an expert. I tell them I know less about it than you know about it. You have done more research. But I often tell them, I know that my drugs will cause side effects. And if they cause side effects, I know how to prevent them. And I know if they happen, how to catch it early. And keep the side effects at a level where it does not harm you. And I can do it only if you don't mix up with something else, which I don't understand. So my answer is very simple. Nothing comes without side effects, not in rheumatology and not in any other field. Now let's come to the absolute answer. How much side effects are we talking about? Let's take methotrexate. I'm saying this again because a lot of medical community has fear about these drugs. So methotrexate, the drug that is my gold standard drug, the go-to drug. If I see a patient of rheumatoid, my first prescription I'll write, unless there is a plan of pregnancy, is going to be methotrexate. And there is no two ways, no guideline, no practicing rheumatologist will stay away from methotrexate. It is something that I'm so comfortable with that I am not at all afraid of methotrexate. And in the last, I've been practicing for at least 12 years now. How many people have landed up in a hospital, ICU, that level of toxicity with methotrexate? Answer is 0. 0, straightforward. How many people have had a major adverse effect for which the drug had to be permanently discontinued? Probably less than 0.5% in my practice. And what was that major adverse effect? The SGOT-PT started rising up. I stopped the drug. It came back. I started the drug. It started rising up again. I never gave the drug again. That's it. This has not changed anything for the patient's life or any major life-threatening problems. The fear comes from the idea that these are anti-cancer drugs. The idea which comes from pharmacology, or at least way back in pharmacology, but let's be very clear, methotrexate in the dose that a rheumatologist will use is definitely not something that my oncology friend wants to use. He will laugh at me because it will not work anti-cancer. Is it immunosuppressive at the drug that I use? 25 milligram per week is the dose of methotrexate. It's a weekly therapy for all the residents here and the undergraduates here. It's a weekly therapy. The 25 milligram, which is the top limit of methotrexate that I will use, is not even completely immunosuppressive. It will not really stop the B cell, T cell or neutrophil. It is anti-inflammatory in the sense that it stops adenosine, which is the molecule responsible for inflammation. That is it. Which means, if I have an example, I have a patient who has, let's say, some kind of a minor infection going on, not something requiring IV antibiotics. Can I continue methotrexate? Very often the answer is yes. That is what we are talking about. That is the level of safety we are talking about now. We are probably still carrying as a community, medical community, an idea of methotrexate which is honestly long lost. In fact, my big guns today are the tofacitinib and the upadacitinib, the new drugs. They are very strongly immunosuppressive. And we find, unfortunately, methotrexate ka dar itna hai that today, at least in Mumbai, general practitioners, MBBS and BHMS doctors are writing tofacitinib as if it's a toffee. It's not a toffee. It's a big gun. I will not give that one without screening. I will screen my patient. I'll do a lot of things. I'll vaccinate the patient before I give those drugs. But again, methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, now the newer one, iguratimod, these are reasonably safe. And they are definitely safer than steroids. They are definitely safer than long-term of painkillers. And if I may now put out my neck and say, they are definitely safer than the alternative therapies that are also existing in the market. But that's not my area to go.
I'll add to, can I add to this? Yeah. We've been using, I'm there for 40 years of it. We've been using methotrexate for more than 30 years now. Hello? Yeah. I've been using methotrexate for more than 30 years. And this dose of, I start with 15, I don't start with 25 also. Only if somebody needs, I go to 25. 15 I think is my most standard dose which I use. once a week, it doesn't cause any problem. Now, I can tell through experience. And we do SGUTs every 6 months, and it really doesn't cause any problem. It's a good, wonderful drug. If at all patient has problem with hydroxyquinoline sulfate, they may have problem with sulfasalazine, they may have problem with the other leflunomide, but never, I have not seen a single patient have a problem with methotrexate. Once a week, that's once a week, 15 milligram, maybe up to 25 milligram once a week. It's really safe. And the way I explain to the patient, now a lot of patients are educated, they look up Google and Chat GPT and all kind of things. So you're giving us an anti-cancer drug. The simple way I explain to the patient is, each drug has a different role at different situations. Like you are a person, you are sitting in front of me as a patient. When you go home, your wife, you're a husband. Your parents, you're a child. To your children, you're a parent. You play different roles, don't you? Being one person, you play. So this kind of drug plays this role in this situation. That's the way, and most people will accept that.
Yes, so one more question, sir. Myself, Dr. Rajiv Munde.
We'll take this last question.
Yeah.
That's fine.
So, the DMRD, which is the first line, methotrexate, leflunomide.
So please hold mic near.
Sulfasalazine. Do you give the same DMRD? Those are the seronegative rheumatoid arthritis, or you treat differently for the rheumatoid arthritis, and those are seropositive and seronegative? That's
Sorry, I'm not able to get your question.
So
You are not audible.
Yeah.
Please hold the mic near and.
DMRD is the first line for the rheumatoid arthritis. Do you recommend the same medicines for seronegative rheumatoid arthritis, or it is different from the seropositive rheumatoid arthritis for DMRDs? That's my first question. And second question is that before surgery and after surgery, what is your stand to start and stop the DMRDs? That is the first line medicine.
So the first question is, are the same DMARDs used in seropositive and seronegative RA?
Yes, sir. Yeah.
Right? Can I take the question? So the answer is yes. One catch, when I label it as seronegative RA, I have to be sure that I am not mislabeling a psoriatic arthritis, because that will also be seronegative, and I am not mislabeling a SLE case or a systemic sclerosis case as seronegative RA. Because seropositive RA has a test which is obvious. But if there is seronegative, I should make an extra effort to search other symptoms and other systems. If the patient does not have a multi-system SLE or something, which right now is just showing arthritis to me. If I am reasonably sure of that, then the treatment is pretty much the same. What is the difference between seropositive, that is rheumatoid factor, anti-CCP positive RA, and a negative RA? At the best, the difference is in prognosis, that patients who have positive rheumatoid factor, positive anti-CCP, in the long term will actually do worse. They might require longer therapy, they might require usually more drugs, and unfortunately they will have more systemic complications like RA vasculitis, RA ILD, and maybe other nodules, etc. So scleritis, so those complications beyond the joint are more likely if rheumatoid factor and anti-CCP is positive. So I'll watch out for that. But the primary initiation of treatment is the same. The second question, sir, was surgery. So from our side, if we are looking at conventional DMARDs, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide we don't use now, I don't use a lot, but if it is that used, they don't need to be really stopped for any major surgery. They can be continued through the surgery with appropriate monitoring. We are talking about orthopedic surgeries here. For a lot of our patients will come to you for surgeries, and usually the drug does not need to be stopped. If the patient is overall a frail patient and the disease is well controlled, maybe stopping for a week to 2 weeks at the best can be clinically decided between the surgeon and the rheumatologist. That's only if the patient is frail. You know, I'm seeing someone 60, 75-year-old, koi other comorbidities, bahut hai, diabetes uncontrolled, maybe I'll stop for some. What needs to stop are the newer drugs, because they are very potent. So what needs to be stopped is tofacitinib, upadacitinib, biologics. They should be stopped definitely 10 days to a 2-week period before. They have a short half-life, so they can go off the system. We have to remember methotrexate has a very long half-life. So even if I stop, वो हमारे मन की शांति है कि हमने कुछ नहीं दिया, system में drug तो चल ही रहा है. So it's a long half-life drug, but the newer ones are short half-life. We can stop them and reasonably put the patient through surgery and restart maybe once you feel that the wound has recovered well. Some 5-10 days, whenever the surgeon feels the wound is recovering well, we can restart.
So thank you very much, sir, about that great insight into the topic. So today's discussion highlighted the RA management, rheumatoid arthritis management, is strongest when inflammation, mindset, mobility, and long-term rehabilitation addressed together. The future lies in combined multidisciplinary approach for the management of rheumatoid arthritis and similar arthritis which are immunomediated. So I really thank all the panelists who took out the valuable time from their busy schedule for joining us on this panel discussion and putting insight into the very difficult topic of bridging joint mind medicine in rheumatoid arthritis. Thank you all the panelists, and also thank you all the audience for being the part of this session and having the wonderful questions towards our panelists and participating in the wonderful discussion. Thank you very much. I announce this panel is over today. Thank you very much.
I thank all the panelists for such a great discussion we had. We all learned about the newer perspectives about the holistic approach towards rheumatoid arthritis and how to go about it in the view of orthopedics, rheumatology, physiotherapy, and psychiatry. I thank you all again. I request a big round of applause for all the panelists. I would like to call Dr. Sachin Naik, Professor and HOD Surgery, to felicitate Dr. Ratna Parki sir and Dr. Sushant Shinde sir. I call upon Dr. Sandhya Kulkarni Madam, Vice Principal, to felicitate Dr. Dabholkar sir and Dr. Smita Panse Ma'am. Thank you, Naik sir. Dr. Sandhya Kulkarni Madam, please. I call Dr. Sushma Sharma Madam to felicitate Dr. Anish Bhatt sir for conducting this session very smoothly. I request all the panelists to please come along for a group photo.
Thank you, dear panelists and Dr. Anish Bhatt. We'll be starting with the valedictory function. Please give us a few moments as we prepare the dais. Thank you.
Gentlemen, myself Dr. Gauri Yadav, on behalf of the organizing committee, I extend respected dignitaries, delegates, colleagues, students to the valedictory function of 13th Annual Research Conference, Mind, Moment, Medication and Integrated Approach to Healing. After 2 enriching days filled with scientific deliberations, paper presentations, poster sessions, data analysis, we finally arrive at the most awaited moment, the grand conclusion of this academic celebration. Today is not just about closing a conference, it is about celebrating knowledge, innovation, dedication, and excellence in research. I hope you all have enjoyed this academic feast. So to begin this valedictory function, I would like to welcome all our dignitaries on the dais with a big round of applause. Our respected Executive Director, Madam, Dr. Suchitra Nagre, Madam, Dr. Darpan Mahesh Gauri, Medical Superintendent, Dr. Deepa Nair Madam, Principal, MIMER Medical College, Dr. Anish Bhatt Sir, Professor and Head, Department of Psychiatry, Dr. Santosh Borkar, Professor and Head, Department of Orthopedics, and Dr. Ganesh Pentewar Sir, Professor and Head, Department of Pharmacology. We are truly honored by their presence with us today. To set a tone of harmony, positivity, and gratitude, may I request everyone to kindly rise for MIRE MIT Pune's World Peace Prayer, composed by our own founder president, Dr. Vishwanath Karad sir. Let us join our hands and hearts in prayer for peace, compassion, and collective well-being.
नमो जीयाद्या वेद प्रतिपाद्या जय जय स्वसंवेद्या आत्मरूपा देवातूति गणेषु सकलार्थमतिप्रकाशु म्हणे निवृत्तिदासु अवधारि बोधि गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरुसाक्षात् परब्रह्मा तस्मै श्री गुरवे नमः। पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते। ॐ शान्ति शान्ति शान्तिः। हरि ईशावास्यमिदं सर्वं यत्किञ्च जगत्यां जगत् तेन त्यक्तेन भुञ्जीथाः मा गृध कश्चिद्धनम्। ॐ भूर्भुवस्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो न प्रचोदयात्। सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखमाप्नुयात्। द्यौ शान्तिः अन्तरिक्षशान्तिः पृथिवीशान्तिः आपश्शान्तिः औषधयशान्तिः वनस्पतयशान्तिः विश्वेदेवाशान्तिः ब्रह्मशान्तिः सर्वशान्तिः शान्तिरेव शान्तिः सामा शान्तिरेधि। ॐ शान्ति शान्ति
Thank you, everyone. You may kindly be seated. There is a slight change in the program that we have made. We are taking the felicitation of MMC Observer first. We are deeply honored to have with us today the MMC Observer, Dr. Nandakishore Mantri sir, whose presence has added immense value to this conference. Dr. Mantri is a senior years of rich clinical experience. He completed his MBBS in 1977 and Diploma in Child Health in 1980 from BJ Medical College, Pune. May I request Dr. Suchitra Nagre Madam to kindly felicitate Dr. Nandakishore Mantri sir. May I call upon stage Mantri sir, please. Sir is an active member of Indian Medical Association, General Practitioners Association, and IMA College of General Practitioner, and has held several prestigious positions. Among his many accolades is the Best Family Physician Award by KDA. We truly consider ourselves fortunate to have such an experienced and esteemed MMC observer for our conference. Thank you very much, sir, for gracing this occasion. Thank you very much, sir. So to commence the valedictory ceremony, I now invite our organizing chairperson, Dr. Anish Bhatt, sir, to deliver the opening remarks.
Good afternoon, all. So, delivering a lot about the event, bringing out your own opinions, experiences, and delivering it to people in a very good sentences. So, as it said, knowledge grows when mind meet and wisdom deepens and when heart listens. With benevolent blessings of our revered patron, Professor Shri Dr. Vishwanath Karat sir and Dr. Suresh Ghaisa sir, the steady guidance of our esteemed Executive Director, Dr. Suchitra Nagre Madam and Dr. Virendra Ghaisa sir, and under the visionary leadership of our Principal, Dr. Deepa Nair Madam, the 13th Annual Research Conference 2025 unfolded as a celebration of inquiry, intellect, and inspiration. What began as an academic endeavor blossomed into a two-day symphony of science, reflection, and collective growth. The conference stood tall in the academic richness, hosting 4 scientific sessions by eminent guest speakers, a thought-provoking keynote address, and an engaging panel discussion featuring 4 distinguished experts. The scholarly spirit resonated through 14 faculty papers, 7 faculty posters, 22 postgraduate papers, 37 postgraduate posters, 7 undergraduate papers also, with more than 340 delegates in attendance, including 42 external delegates and 6 undergraduate students. The gathering truly embodied the essence of vibrant academic confluence. The day 1 dawned with the faculty paper presentation, setting the tone for thoughtful discourse. This was followed by insightful session by Dr. Arjun Dhawale sir, whose talk on approach to backache blended clinical acumen with practical wisdom. Dr. Jayesh the hall with her session, Pills, Pain and Perception, a multidisciplinary approach to rational pharmacotherapy, reminding us that medicine is as much as an art as it is a science. The keynote address by Professor Dr. Henal Shah Madam was truly a moment of pause and reflect. To heal is not only to repair, but to rewire. She conveyed as her practical approach to enhancing resilience and facilitating the neuroplasticity opened new corridors of thought. The audience listened in rapt attention, inspired by perspectives that bridged neuroscience and live experience. The unveiling of the conference souvenir by our esteemed guests added the ceremonial grace, while our executive directors shared reflections on legacy and value of annual research conference and the enduring spirit of Mimar family. Simultaneous poster and paper sessions followed simultaneously paper and poster sessions followed. An academic marathon seamlessly orchestrated by our scientific and poster committees, culminating in a well-earned lunch that fostered informal exchanges and camaraderie. The day 2, that is today, carried forward the same intellectual vigor, beginning with the postgraduate poster presentation, followed by the session. Dr. Dhananjay Asturkar, eminent psychiatrist, session was both profound and persuasive. As he explored the psychological determinants of physical healing, his words reaffirmed a timeless truth. The mind and body are not separate chapters, but pages of the same story. This was followed by a forward-looking session by Dr. Deepak Langde sir, Professor and Head of the Department of Pharmacology, D.Y. Patil Medical College, Navi Mumbai, on intelligence in innovation, the role of artificial intelligence in next-generation drug delivery. The discourse sparked curiosity and dialogue, opening new vistas of technology's expanding role in healthcare and medicine. The afternoon panel discussion, from inflammation to rehabilitation, bridging joint, mind, and medicine in rheumatoid arthritis, was a highlight of the conference. Eminent panelists Dr. Shailesh Ratnaparki sir, Dr. Sushant Shinde sir, Dr. Smita Panse madam, and Dr. Ajit Dabolkar sir captivated the audience with their depth and insight and collaborative vision. The discussion culminated in shared resolution, the indispensability of the integrated multidisciplinary care in managing rheumatoid arthritis is very important. Behind the scenes, what began as an apprehension, organizing a conference as a relatively small department along the side of pharmacology and orthopedics, transformed into a smooth and rewarding journey. With unwavering support from seniors, colleagues, mentors, challenges dissolved into learning experiences. The 2 days were rich, not only in the knowledge and research, but also in interaction, laughter, resilience, and self-beliefs. Bonds strengthened, confidence grew, and the courage to lead, decide, and innovate took root. Yet reflection also invites humility. Every success carries a lesson. Every lesson prepares us for better tomorrows. Recognizing the need for structured standard operating procedures for committees and clearer role of delineation will guide us towards even more smoother and more stress-free conferences in future. Though in these conferences we were very less stressful. In closing, I would like to say the echo of ideas shared here will travel far beyond these halls. The insight gained, the question raised, and the connection forged will continue to shape our academic journeys. These conferences did not merely conclude in kindled a promise to do better, think deeper, collaborate stronger, and move forward with renewed purpose. Thank you very much.
Thank you very much, sir, for those glimpses and reflections of the Annual Research Conference 2025. Moving ahead, we all know the toughest job in this whole 2 days was done by none other than by our judges. They evaluated presentations spanning diverse disciplines, from operative interventions to public health perspectives, with great dedication and academic rigor. I now invite our respected judge, Dr. Yuvraj Badhe sir, to share his observations and remarks on behalf of all the judges. Dr. Badhe sir, please. Dr. Badhe sir is professor in medicine at D.Y. Patil Medical College, Ambi right now, but we all also know that he was a professor in our own institute.
Good evening. It's like feeling back to my home. It has some emotional attachment with this institute. It's not an institute for me, it has something more than institute. Thanks for inviting me as a judge here. As an individual, at the same time, on behalf of other judges, I discussed with other judges also. I got their feedback and I will share that feedback also. Very well organized and all paper presentations, minute to minute, and started in time, finished in time. One of the judges said that the papers and the research should be done, more research should be done in prospective studies. So all papers are presented very nicely, and I thank the annual research conference committee for inviting me. Last year I had that feeling that I am missing something, but that was the only last year. This year I again came here and enjoyed a lot. Thank you very much.
Thank you very much, sir, for your feedback and the encouraging words. We will certainly take the suggestions of all the judges forward as we continue to improve and grow. So here now comes the most awaited moment of which everyone is eagerly waiting for in this conference, that is the declaration and distribution of prizes. These awards present much more than performance during the conference. They reflect weeks of preparations, reading, revisiting, reanalyzing data, and sometimes rewriting the entire study because the statistics change and the scientific committee insisted on yet another correction. So this celebrates perseverance, dedication, and the true spirit of scientific inquiry. So I request our respected dignitaries to kindly do the honors. So to begin with, we'll start with the category of prizes in the UG section first, UG papers. We are all very delighted to say that there were 7 presentations by the UG students in the UG paper category, and all were really very good. Even all the judges appreciated these UG presentations, the paper presentations. And the prize for the UG paper presentation goes to Dr. Naveen Kirti from 3rd MBBS Phase 1. Dr. Naveen Kirti, please give him a grand round of applause. Dr. Naveen is very interested in the AI and machine learning, and he has presented a very complex paper where algorithms and everything was included. Quite difficult to understand for the medical faculty, but he's obviously belongs to a new generation and they are entering this new sector. This is a very delightful thing for us. The second category is we are starting with the postgraduate residents presentations. The first is PG paper category. So the third prize of the PG paper category, it goes to Dr. Bhagyashree Agarwal from Department of Dermatology. Please give her a big round of applause. Dr. Bhagyashree. The second prize for the PG paper category goes to Dr. Akshay Raut from Department of Ear, Nose and Throat, Otorhinolaryngology. Please give him a big round of applause. Dr. Akshay Raut, please. here comes the first prize in the PG paper category. Any guesses who has won the prize? None other than the Department of Psychiatry, Dr. Bhagyashree More. Dr. Bhagyashree More, please. We are moving to the PG poster category now, and the third prize for the PG poster category goes to Dr. Isha Jaiswal from Department of Anesthesia. Dr. Isha, is she present here in the auditorium? I think she is not here. The second prize, anyone from the anesthesia department on her behalf can receive the prize, please. So the second prize for the PG poster category goes to, again, Department of Dermatology, Dr. Bhagyashree Agarwal. This is the second prize for her in both the categories, that is the PG paper and PG poster category. The first prize for PG poster category goes to the second organizing department of this ARC, that is Department of Pharmacology, Dr. Pooja Patil. So in the PG category, I suppose the organizing departments have bagged the prizes. Dr. Pooja Patil, heartiest congratulations. Heartiest congratulations to all the PGs who have won the paper and the poster prizes, as well as all the presenters who have presented very well in this ARC 2025. Moving ahead to the faculty paper and the poster category. Any guesses who has won, which department has won the faculty paper? Second prize, sorry, second prize? No? Dr. Gauri Metkar from Department of Pathology. Dr. Metkar and Bhatt collaboration is very strong in this ARC. Congratulations, Dr. Gauri Madam. And there is a tie-up in the faculty paper for the first position. It is between Dr. Santosh Kumar Rajamani sir from ENT department and again Dr. Anish Bhatt from Department of Psychiatry. Dr. Santosh Kumar Rajamani and Dr. Anish Bhatt received the first prize in the faculty paper category. Congratulations to all. Please give them a big round of applause. The Mentorship Committee of MIMR Medical College and the IQAC from this year has started a new initiative, that is the Mentorship Awards. This is to encourage the mentorship program that our own institute conducts for new students as well as the old students, and this is basically to strengthen the bond between the mentor and mentee. Okay, the faculty poster prize again goes to Dr. Anish Bhatt sir from Department of Psychiatry. Organizing departments are rocking in this conference. Congratulations, Dr. Anish sir. Moving to the Best Mentor Awards. Behind every confident student stands a mentor, someone who believes, guides, corrects, inspires, and uplifts. So, our institute has proudly started a new tradition, the Best Mentor Award in this ARC. So, it is now time to honor one such a pillar of guidance. We are going phase-wise. So, starting with the phase 1, it is Dr. Vivek Nirmale who is awarded as a Best Mentor. And this, I'm proud to say that the Google forms were distributed between the students to choose their best mentor. And the students have chosen Dr. Vivek Nirmale from the phase 1 as the best mentor. Give him a big round of applause, please. Okay. For the second MBBS academic year, it is Dr. Ganesh Pentewar who receives the Best Mentor Award. Give him a big round of applause, please. For the third MBBS Phase 1, Dr. Devadatta Kotnis sir. Anyone from Department of ENT can receive the award on his behalf. Dr. Santosh Kumar Rajamani is coming. For the third MBBS Phase 2, it is none other than Dr. Sudeep Kumar who has received the Best Mentor Award from Department of Medicine. He belongs to Department of Medicine. Dr. Sudeep sir. Anyone from Department of Medicine? Dr. Madhu madam is coming to receive the award on his behalf. Congratulations, Dr. Vivek, Dr. Ganesh sir, Dr. Kotnis sir, and Dr. Sudeep Kumar sir. Give them a big round of applause. And the overall Best Mentor Award goes to Dr. Sudeep Kumar sir again. May I request Dr. Madhu madam to receive the award, please? To bring together today's experiences, reflections, and future direction, I now invite our dynamic, ever-charming, and inspiring guiding force, our respected Executive Director, Dr. Suchitra Nangre Madam, to deliver the concluding remarks. Okay. Oh, sorry, I missed the most exciting thing, that is the lucky draw. Very sorry. Let us see who is the chosen one in today's lucky draw. And the lucky person is
Hello. And the lucky draw winner is Dr. Harsh Desai from Dentistry. Is he around? Dr. Harsh Desai. In absentia, we cannot give the award. Get the box. Dr. Tejasvi Zadhav.
Oh, she's there. Dr. Tejasvi Zadhav from Department of Pathology. So she is the lucky person in today's lucky draw. Thank you all the dignitaries. You may please be seated after this. Thank you all. May I now request our dynamic, ever-charming and inspiring guiding force, our respected Executive Director, Madam Dr. Suchitra Nagre, to deliver the concluding remarks. Madam, the stage is yours.
A very good evening to all of you. Congratulations to all the faculty members of Department of Psychiatry or 13th Annual Research Conference on 18th and 19th. And congratulations to all the winners and participants. I don't have much to say today because yesterday we had a wonderful inaugural, and thank you for getting Dr. Shah ma'am. Even for today's panel discussion, I was just thinking, when I was sitting in audience, I was just thinking that though we all are medicos, when it comes to some common diseases, we are not having that in-depth knowledge or what is required, what is to be done, what advice you can give to the people, but some other disease. And the rheumatology topic was, I think, very common, and Anish, you conducted it very well. So I'm so happy that since COVID, we started this panel discussion, which gives the insight of a particular topic from different perspective related to that disease. I'm so happy today that today in Mymar Medical College and VSTR Hospital, 1925 साली भाऊसाहेब सरदेसाई हॉस्पिटल निघालं होतं आणि 2025ला आत्ता 100ही साजरी झालेली असताना आज 19 डिसेंबर 2025 आज शेतकऱ्यांसाठी खूप मोठा दिवस आहे. दर्शवेळ अमावस्या आहे आणि सकाळी मी विचार करते की प्रत्येक दिवस आपण वेगवेगळ्या दृष्टीने कुठल्याही सिच्युएशनकडे बघतो. ह्याच्यावर काल बरंच डिस्कशन झालं. सो आय जस्ट वंडरिंग की आजचा दिवस काय विशेष आहे. कोणी म्हणेल अमावस्या आहे, कोणी म्हणेल रिसर्च सोसायटी कॉन्फरन्सचं कन्क्लुडिंग आहे. पण फॉर अस इट्स अ बिग डे फॉर BSTR that today we had the first CABG done in BSTR hospital successfully, and the patient is recovering well in ICU, and thanks to Ruby Healthcare and their team for holding hands with Mymar Medical College and coming up with this facility wherein now the poor patients are having a good facility about angiography, angioplasty and CFBG. And I'm sure that under the able leadership of Dr. Darpan Mahesh Gauri, this hospital will do wonders with the help of all the clinicians and PG residents. Today I'll just say that when I was observing this conference since yesterday, I just felt few things which I must convey myself. First thing is attendance of faculty in the hall. So what I observed is we take this as some celebration, but it is an academic program and we must take academic programs as academic programs. In the social programs like Plexus, Vakratunda or ADU, where we are seeing of the student or welcoming the students, that programs are having different level of conduction. But when we speak about the word research, we are speaking about the medical academics, the development in our field, and also we want to know the angles from different perspective of different specialities in this forum. But when I was observing today morning, the attendance was very less. I could see people meeting after many days and standing here and there in the entire premises. So I expect a better attendance by the faculty. I also suggest the organizers that maybe from next year, for the relevant topics, we can invite our undergraduate and postgraduate students for specific lectures. For example, call the second year students for particular lectures in this hall. All said and done, I think congratulations to all the winners, congratulations to Anish and Ganesh and Borkar sir and team, and all the people who helped to conduct this program successfully. For the next 14th Annual Research Conference, Department of Anesthesia, Department of Anatomy and Radiology will be conducting the 14th Annual Research Conference of Mymar Medical College. Once again, thank you all of you and have a wonderful evening and have a great weekend. Tomorrow we are having alumni meet. So I request all of you to attend this alumni meet. because the students are more keen in meeting the teachers rather than the administrators or the setup. So I expect maximum people or maximum faculty like Sandhya and senior members who taught these batches, who are completing 25 years of their MBBS admission. Once again, thank you everyone and have a wonderful evening.
Thank you very much, madam, for those inspiring words. And to add to what madam said about tomorrow's program, Reminiscence, we have received more than 80 registrations till now for the alumni meet, and that batch, that is year 2000 admission batch, is very enthusiastic and they are very eager to meet all the faculty personally, and they have planned a good event. So please do come for the event tomorrow. So no event of this magnitude is possible without the tireless efforts of a dedicated team working behind the scenes. To express our heartfelt gratitude, I invite our organizing chairperson, Dr. Santosh Borkar, Professor and Head, Department of Orthopedics, to deliver the vote of thanks. The mic is yours, sir.
Respected dignitaries on and off the dais, delegates, faculty, students, and teaching and non-teaching staff, being given opportunity to give valedictory Thanksgiving speech. Over last 2 days, we have experienced huge academic and research bonanza. I hope we have been successful in achieving the broader goal of promoting research aptitude among students and faculty, and fueled academic progress and innovation in this institute and among the participants. We feel that we have been able to do justice to the theme of this conference, mind, movement, and medication, an integrated approach to healing. On behalf of the organizing committee, we express our sincere gratitude to our patron, revered Indian educationist, scientist, and visionary reputed Professor Dr. Vishwanath Karad, sir, for all his blessings. We are deeply grateful to our Honorary Executive Director, Dr. Suchitra Nagare, Madam, and Dr. Virendra Gaisa, sir, and Principal Dr. Deepa Nair, as well as Medical Superintendent, sir, for all the guidance and support as always. We thank our chief guest, Dr. Henal Shah, Madam, for accepting our invitation and delivering keynote address. I also thank all the eminent speakers, panelists, the judges for sparing their valuable time and giving their expertise and adding spice to our conference. I thank all the delegates for being part of this conference, and many of them presented papers and posters, and that elevated the level of this conference. We congratulate the winners of this conference. We congratulate the MMC Observer for supervising this event. We thank the administrative department for their support, as well as other departments and individuals for helping us with the venue arrangements, logistics, audiovisual arrangements, IT assistance, photography, printing work, transport facilities, refreshments, and everyone else. I can see that so many people were involved that it is not possible to name a few of them. We appreciate the efforts taken by the Annual Research Society committee members. There were so many committees, and each of them was perfect in execution of the task given to them. I'm really thankful to all of them. I'm thankful to the residents, interns, as well as the teaching and non-teaching staff for contributing to the success of this conference. I thank all persons who directly or indirectly contributed to the success of this conference. We wish everyone success in their future academic and research endeavors. Thank you.
Thank you, sir. And with that, ladies and gentlemen, we come to the end of this beautiful academic journey, the 13th Annual Research Conference of MIMER Medical College. As per MIMER tradition, we conclude every function by expressing our gratitude to the Almighty. May I request everyone to kindly rise for Prasadhan.